All right, so we're going to record. We've got a couple of things we're going to go over today. We're going to obviously start with thorax, and then the end of it kind of ties to both thorax and knees because we're going to talk about plans of care and how to look at plans of care, how to read plans of care, just have a general idea. I'm going to talk about your final, and I'm going to talk about next week. That is the plan for today. So for those of you that don't know, next week we're officially supposed to be starting lab. I'm waiting for some information from Dr. Reskin and also some information from the school, and I will have more information on that for you. And then talk kind of about what's going to go on through finals. Your final is going to be online. Unfortunately, it's not going to be as easy as your midterm was. Wink, wink, nudge, nudge. But it will definitely be reasonable. I'm not going to make the final where it's torturous. You know, the original final for this class, because this is the longer of the two classes, was 165 questions. I'm not going to make it 165 questions. Well, my goal for the 165 questions was to get you guys used to sitting for 150 questions plus. It doesn't work the same when you're at home, because when you're at home, you can pause final and come back to it, and you don't get the same experience of just sitting there for an extended 3 hours. I'm really worried about that for people that are going to take the boards for the next probably year or so, is that they're losing the endurance to sit for long periods of time. It is, yeah, honestly, it is until you're sitting there answering questions for 200 questions. At about that point, then sometimes your brain goes haywire and splits off. But yeah, so that was the idea of the finals that I gave in this class. It was kind of prepping you for getting ready for your boards. Can't do that as much. Dr. Reskin and I are working on next semester already. You guys, I'm going to actually pause recording real quick. Be right back to recording. All right, so start with the ankle and foot. So what bones make up the ankle mortise? So when I say mortise, what does mortise mean? Like Rick and Mortis, right? Yeah, mortise actually comes from the term death, right? And a pestle and mortise is where we kind of grind stuff up, which is not very similar to dark minds. Yeah, and this time with the Rona, we have dark minds. So mortise is what kind of makes up the structure of our ankle, right? It's the shape of our ankle. So our main ankle is made up primarily of our tibia articulating on what bone? What bone does our tibia primarily articulate with? The talus, right. Now we have obviously our fibula, which helps us with balance, and we have our calcaneus, which is our plantar surface, but that's primarily most of our ankle, right? So here's our tibia, right? Coming down, tubby tibia, fine fibula, comes down and makes a talocrural joint. And when you see crural means ankle. And then below it, we obviously have our calcaneus, we have our navic, and our cuneiforms. I don't know why, but I think I said in kines, I just like the term cuneiform. I just think it's a really cool term for bones. We have cuneiforms on our feet. Our cuneiforms go over to our cuboids. Then we've got our metatarsals and our tarsals and all that fun stuff, right? So the leg, which is the crural part of our body, right? It also is sometimes referred to as the sural part, which is the calf portion, which is primarily our tibia and our fibula. Then we come to our hind foot, which is our talus and our calcaneus we talked about, midfoot, navicular, cuboid, and cuneiforms, and then our forefoot. And we have, our 5 metatarsals and 14 phalanges, but why don't we have 15 phalanges? Why not 15? Why can't things be nice and even? Yeah, they're still the same way, right? Exactly. That's why I like them. That's okay. I understood what you're getting at. What toe is missing a phalange? Why do we end up with only 14 and not 15? Other side. The big toe, right? The big toe is the thumb of the foot. And I'd be really curious if we go back in evolution as to why that happened. Like, why did we not develop an extra, joint on our thumb? to make things more interesting, it would definitely affected grip, right? I think it's because of power, because that thumb is designed for power more than it is for fine movement, where the fingers are. Think about when you pick stuff up, right? When I pick stuff up, I hold it and the thumb's got the grip down on it. Big toe is kind of the same way. Big toe helps us with push off, right? If you don't believe that your big toe helps you with push off, break it once. Or step on a tack and get a sore spot on your big toe. And then watch how hard it is to walk. It seems like such a silly thing, but for some reason, that big toe is really responsible for when we get that good, nice push off going. So we talked about the planes of motion already. And again, a lot of these lectures are designed to go coincide with each other, so it beats it into your head. So that, well, that's not technically beating in the head, is not the term for it. Technically, the term is learning over time, but I like beating over your head. Right, so we have dorsiflexion, plantar flexion, inversion, eversion, abduction, and adduction. And then we have our triplanar motions, which are pronation and supination. And when we're talking about walking, gait, problems with the foot, these are two of the biggest terms we worry about, because this tells us a lot about the way their foot is rolling through when they're walking. So there's a dorsiflexion, there's a plantar flexion, right? Abduction, adduction, right? When we look at this, it's talking abduction and adduction is when the foot turns away from midline. It's just like everything else. So when we look at the joints going down the ankle, so first of all, we have the superior tibiofibular joint, right? It's a planar synovial joint, it's fibular head, and the facet of the posterior lateral aspect of the condyle of the tibia. What that allows us to do is have a nice stable surface where that fibula locks in to the tibia. And why we want that is for the transition of ground forces when we're doing balance. That sends a lot of that force up there and locks it in, so that when we have balance stability problems, when we're moving our ankles around, stuff like that, it can kind of lock into that tibia and provide a double support beam. The inferior tibiofibular joint is the synemosis with fiber adipose tissue, right? That's that synemosis joint that runs down between them. And then we have the tibiofibular ligaments, which keep everything nice and tight. There is slight movement in that joint. So there is slight motion going on between the tibia and the fibula. It is nowhere near the motion that occurs with the radius and ulna, right? We don't have pronation, supination of the crural section of our leg, right? It just doesn't happen. That would be really weird. Just imagine, like, if all of a sudden you could turn your foot backwards. I mean, I can almost get there, but not quite. But I mean, that would look kind of weird, right? All of a sudden we turn our feet backwards and, you know, run like a ostrich or something. And we get down to the ankle, we get the talocrural joint, right? So talocrural is a synovial hinge, and excuse me, when you look at it, it looks like a hinge joint because it kind of rotates like this. And there are some accessory motions that go along with it, but primarily it's that dorsiflexion, plantar flexion point. The ankle mortise, or the main part of the thing you'll hear about with surgeons, because that's what the mortise really deals with, is the distal end of the tibia, including the tibial mal, the fibular mal, and the trochlea of the talus. And that's where we get into that trimalleolar fracture occasionally. It's got a very weak capsular hold. And this is important because this allows us for maximal mobility, but it also then allows us to do what more commonly to the ankle? If it's got really weak capsular hold, it's going to open us up to rolling. Yeah, right? That's why we injure our ankles so frequently. It's just because it's designed for maximal mobility and absorption of the shock forces and the way that the foot kind of adheres to the ground, because your foot changes shape based upon the ground you're on. The fibular malleolus extends farther distally and posteriorly than the tibial, right? So that fibular malleolus ends up a little bit longer down than the tibia does. And again, that's primarily for balance's sake. And our closed pack position is dorsiflexion. Our open pack position is slight plantar flexion, or what we would literally call resting position. So that if you hang your feet off the edge of a bed in short sitting, your foot kind of drops down into a little bit of plantar flexion. That's kind of resting position. That's where we mobilize things. So here's a huge slide of the roll and spin and slide of, no problem, Emily. The roll, spin, and movement of the ankle. We're just getting started anyway. And it helps if I didn't, you know, just spill coffee on my face. Yeah, I saw that live. That was fantastic. I have a hole in my mouth. The main idea is it's just like everything else. When you're looking at the roll and slide, you've got to be thinking about whether it's convex or concave on convex, because the ankle can be both, right? Can you give me an example of an open chain movement in plantar flexion? How would you do open chain exercises in plantar flexion? What do you think? So open chain is when the distal end is not fixed. Okay, flutter kicks would work, right? Or just sitting here at the chair going up and down with the foot, right? That would be an open chain movement of the foot. Splashing in the pool, good, right? So then what would be a closed chain movement of the foot? Can you think of a closed chain movement for the foot? Okay, calf raises, good, right? Anything, even just simply doing what? Standing up, right? Even just standing up technically would be a closed chain movement. Hold on one second. Somebody just sent me about the. So anytime we have those, that's going to change whether the convex is rolling on the concave, or the concave is rolling on the convex, and we have to kind of pay attention to that. So let's think about this for a second. Sit, tot, stand. I like sit, tot, stands. So let's think of the open chain. With the open chain movement, is that a convex on concave or concave on convex movement? So when you're doing open chain movements, what bone is primarily doing the movement? The talus or the tibia? The talus, right? And so the talus is convex on a concave surface, right? Because you have the concave surface of the tibia and the vexing surface of the talus. So that would be an open chain. That means that in closed chain, we'd be dealing with a cave on a vex movement, right? The concave movement of the tibia moving on the convex surface of the talus, right? Those, literally, when you get questions like that on your boards, that's about as hard as it's going to be for those. That doesn't mean they might ask you about roll, spin, and slide, or glide and spin and all that fun stuff. But when they're talking about convex and concave, that's what you guys kind of have to think about. And the best suggestion I can give you on questions like that is draw it or move yourself, right? Because if I get my foot off the edge and I can sit there and go, okay, so I'm doing gas pedals in the air. Okay, I can feel my talus kind of popping as I'm moving around. So that means the talus is round on the top. That means it's convex. And tibia, right? That's kind of what you've got to do to think about through these is actually do a little bit of movement or draw, right? Good news is with the boards now, we're going back to good old-fashioned white paper and pencils, because before we had been using whiteboards where you could write on the whiteboard and then wipe it off, but they don't want to be sharing whiteboards between people because of, again, the coronavirus. So they're giving back to paper. So sit down and draw it out. Okay, here's what the talus looks like. Here's what the tibia looks like. Right. So you're sitting there, and of course, Mr. McKeever drawing's going on here. So we're gonna go, okay. So here's my tubby tibia coming down. Kind of looks like a high heel shoe. Here's my talus. Here's the rest of my foot. So if I'm going down into plantar flexion, that means this is going that way. Draw it out because it'll really help you kind of look through it. So a couple joints that we have down there, right? We have the subtalar joint, the talocalcaneal joint. We have the talonavicular, the transverse tarsal, the intertarsals and tarsometatarsal joints, the metatarsal phalangeal, and the interphalangeal joints. So there are a lot of joints in the foot, right? Just getting down to the foot, you're like, holy crap, there's so much going on here, which is really weird because when we talk about upper extremity therapy, specifically hand therapy, there are very, very, very specific therapists that work in hand therapy. Now, they're usually called upper extremity specialists, so it's not just hand therapy. They also work on the elbow, the shoulder, stuff like that. But we don't, I mean, there are people that specialize in the foot, but there's not really specialist PTs that are like the foot PT. And I wonder why that is. I don't know why. I don't have the answer to this. This is just something these are the musings I get when I'm sitting here looking through the research at stuff, is why is there not specialists on, foot forming and getting the proper arch support and all that? You think there would be at this point. I'm guessing probably at the high level athlete level there's probably specialists that just focus on, people that have Lisfranc fractures and stuff like that. But it just seems weird there's not specialists in feet therapy, and maybe just because it's feet. So there is an interdependence of leg and foot motions, meaning that when the leg does something, the foot's going to do something. When the foot does something, the leg has a response to it as well. In weight bearing, subtalar and tibial rotations are interdependent, right? So there is supination and pronation technically at the foot when the tibia rotates on that talar position, right? But we don't talk about supination and pronation because it just adds a concept that's not really specific to the ankle. If you get really hardcore into looking into foot surgery and podiatry and stuff like that, there are docs that will deal with supination and pronation of that tibia, but it's pretty rare. The arches, right, or the twisted osteoplate, which kind of helps us have that nice high arch. The primary support for all of our arches is our spring ligament. Why do you think it's called the spring ligament? Is it to go with spring rolls? Yeah, because it goes up next. It provides our bounce on our step, right? So the spring ligament is one of our major ligaments that helps keep us kind of, the wonderful thing about Tigers is Tigers are wonderful things, right? Now get that out of your head. You're going to be singing that for the next 20 minutes. Yeah? No one's singing Tiger song. What's that? Should we sing the Elmo song instead? Additional support comes from the long plantar ligament, the plantar aponeurosis, and the short plantar ligament. But in general, in the foot itself that provides the arch, there's not a lot of muscular support that goes along with it. There's a lot of muscles that lay under it and pull into it, but there's not a lot of muscular support of that arch, right? And that's why that arch is so easy to collapse on us if we don't take care of it. When you have excess pronation or excess supination in standing, you end up with planar asymmetry in the frontal plane of the landmarks, either being higher or lower than they should be. All that basically says is if you stand on the outside of the foot or stand on the inside of the foot, it's going to affect where your bony landmarks fall. And it's going to bring you the tibial malleolus or the fibular malleolus in different alignment than it should be. That's going to also open you up to more injuries, right? If you're a chronic overpronator, it's really common for you guys to get medial tibial stress syndrome, right? Just because you're putting a lot of force on that medial bone of the tibia, and it just kind of wears at it, right? If you're a supinator, you have more likely to end up with a rolled ankle, just because that already puts you in a position where your ankle can just roll out on you. So that's going to affect your overall function. So calcaneal varus, calcaneus valgus, and the pes motions of abnormal foot postures here. So looking at a normal heel, if we look at everything from behind, what we should see is when we come down, the mid portion of that calcaneus, that was a really good straight line, Mr. McKeever. Let's get a straight line. the mid portion of that calcaneus should come down and make a 90-degree angle with the ground that we're standing on. Right, so that should form a right angle right there. When we end up with problems is we end up with stuff like this, where we get calcaneal valgus, right? Or calcaneal varus. Now, if you look at this at the ankle, things are changing, because you would think with everything else, when you have a varus or valgus, the valgus is going in towards the body and the valgus is going outwards, right? But again, whenever they named this for you, they were trying to match it up with the knee, right? So if I look further up here, right, my knee is going to be out like that. That means I probably have, right, genu varus, right? Whereas if this is my knee here, I probably have genu valgus and knee. So they kind of match the ankles up. Now, does that mean that you have a patient that's got genu varus that doesn't have genu valgus? It's possible. It's really rare. So usually, again, the hip and the knees are going to be opposite. The knees and the ankles are going to match up. Then we have kind of a normal foot here, right? It's got a nice arch. And then pes planus is that nice flat foot, which, you know, the military really hates, because putting that in a boot is not a healthy thing. What if we have a patient that's got pes planus like this? What do you think we're going to do to them? What's been traditional that we do with pes planus? Yeah, we give them inserts, right? But this is kind of that process that I was talking about a little while ago. I think even Kines were talking about it. But let's think about that. So let's say we have low back pain. The low back pain is caused by weak musculature in the back, right? We know that that's what it's caused by. If we put a brace on the back, will that make the low back pain better? Probably, right? But what's it going to do to all the musculature associated with that? It's going to weaken it, right? So let's think about that from the foot perspective. And I don't know why we've never really thought about this before, but so we have pes planus, and we put an arch support in order to kind of increase that arch. Technically, what's that going to do to the musculature down there? Yeah, it's going to weaken it. So our arch actually becomes worse because we're reliant on that arch support versus working that arch support and maybe bringing that arch back. And we don't, this is something that's up and coming in physical therapy as far as feet go, is that we're really looking at this going, do we want to jump right to an arch support, especially in the case of kids, right? Because we know that kids are very, very plastic, meaning they can be redeveloped. So if the kid's got really bad pes planus and their foot is just collapsed, maybe the idea isn't so much to give arch support to them, but maybe to strengthen that foot so they can actually get their arch back and it can stay longer. It's a really good idea. But let's think about it. When we go buy shoes nowadays, right? You're going to have to buy shoes, except for ladies. I don't know why you buy shoes that are uncomfortable, but I'm going to talk about us normal people. When you go buy shoes, a lot of times you're buying the shoe based upon the comfort of the shoe, aren't you? Right? Just look at some of the shoes that are out now. The Skechers Go Walk Pros with memory foam. It feels like you're walking on a cloud. I could sell Skechers shoes. Right? But is that the best idea for our foot? That we're walking on a cloud? Right? I don't know that it is. It's kind of like, I look at all the nurses getting their super duper comfy, squishy Crocs. And I understand that in a way, yes, those super duper comfy shoes with memory foam are good for transferring ground forces, right? But it's got no support. And that's kind of what I'm thinking about is, are we setting ourselves up in the future to have more problems? I don't know. It's just a thought process, right? Are we setting because even the kids' shoes nowadays, they're like Skechers memory foam for kids. When I see that, I think, well, their shoes or foot are going to collapse, right? And yeah, it does help with ground force transference and it does help with comfort, but do we have to have a comfort life everywhere we go? Right? It's the same idea like if you give an old man like me a huge lazy boy recliner and versus giving me a kind of uncomfortable chair, if you give me a huge comfy lazy boy recliner, I'm gonna spend all day in that recliner watching, football, right? And just being comfortable. But if you give me a chair that's not so comfortable, maybe I won't spend so much time in it and I'll get up and move a little bit more. So I'm just telling you guys that have significant others, maybe you just want to get an uncomfortable chair for them so they do more. I'm just saying. I'm joking. I'm really joking. So plantar flexors, right? Combined known as triceps surae, we talked about already. The two joint muscle, the gastroc, the one joint muscle, the soleus, right? Secondary plantar flexors, we have your tib post, flexor hallucis longus, flexor digitorum longus, peroneal longus, and peroneal brevis. All of those assist with plantar flexion. And that's kind of important because plantar flexion is important for gait. So if for whatever reason the gastroc would become paralyzed, we do have other muscles that can kind of take over and still give us plantar flexion. And it's neat that the body's built in with these redundant systems that if something goes wrong, we have a backup system for it. When we get to the brain and start talking about the circle of Willis, right, you'll be amazed at how the body has backup systems for getting blood to the brain. It's designed specifically so that if one part of the system fails, the other sides can pick up that slack. Same idea down here. We know that we need plantar flexion for gait. So our body's got our gastroc, we've got our soleus, which is one of our strongest muscles by volume in the body. And then if for whatever reason they fail, we've got all these muscles down here that can help with plantar flexion. So they're kind of designed for failure, right? For dorsiflexion, we've got our tibialis anterior and our extensor group, right? But if you look at that dorsiflexion, it's a lot weaker, isn't it? Like tibialis anterior is a good, strong muscle. When we paralyze tibialis anterior, the extensor muscles of the toes are not going to be able to make up for it. Right? It's just not as powerful as that big fat tib ant. That tib ant's a nice chunky muscle, but it gets paralyzed. And that's why we end up with so many patients that end up with drop foot, because that tib ant gets paralyzed. It's really hard to get those toes to substitute. We have our intrinsic muscles. What does intrinsic muscle mean again? If you don't have this beat into you by the time you're done with me, I don't know what will. Intrinsic means what? Yeah, inside, right? So that means the origins and insertions of those muscles are inside the foot, right? Intrinsic. In standing, the vertical gravity line falls the anterior axis of the ankle joint, so just in the middle of that anterior surface of the ankle joint. The soleus will counter the pull of gravity and the extrinsic foot muscles to stabilize the foot during standing and sway. This is why I say that soleus is so important. Your soleus is one of your most important muscles that helps you maintain anterior-posterior posture because it's constantly has an eccentric load on it when you're in standing. And you don't even think about it, right? When you're standing up, you're not actively thinking about that soleus contracting, but it's actively thinking about it. And it's maintaining that kind of posture with you. And that's why it's one of the, it's a big, beefy muscle that does a lot of stuff that helps with it. So let's kind of think through gait real quick. So let me get my little drawer up here. So our first part of gait is when what meets the ground? If we're taking the first kind of step, the heel strikes the ground, right? So our heel's hitting the ground. When that foot comes down, are we eccentric loading or are we concentric loading? So as we swing the foot through and that heel strike comes down, yeah, we're eccentric loading, right? We're slowing that foot down because otherwise that foot just slams down. So now once we get here, all right, we get that heel, so let me bring the camera down. That didn't work out very well. There we go. So once we get here and that heel strikes, that still didn't, let's go back here, there we go. That heel strikes down. The next thing that's gonna come is we're gonna roll through the foot, right? We're gonna go heel all the way out to our toes. So that is going into plantar flexion. Is that active plantar flexion? Are we actively trying to pull that foot down like that? No, right? Really what's happening is the dorsiflexors are slowing the foot into the roll, right? So that's going to be another eccentric motion. And then we're going to bring our leg through. So now bringing that leg through, is that concentric motion? So pulling the tibia into vertical position, would that be concentric? Yeah, that would be, right? So the dorsiflexors are saying, okay, so here's where I'm at, pull concentrically, right? And we're going to pull till we end up at foot flat. Now at foot flat, when we're in this position here, right, pretty much everything's got some load to it, but the soleus is our primary muscle responsible for maintaining the position kind of here, right? It's saying, okay, I'm not going to let you go backwards into plantar flexion. I'm not going to let you go forwards into dorsiflexion until I'm sure what we want to do. So at this point, at this mid-stance portion is where the soleus is probably the most active, because it's really relying on everything else and countering the forces of all the other muscles in the foot going, okay, where do we need to go from here, right? So the next thing we're going to do is start rolling our heel up, right? So our heel's going to start picking up, and we're going to go into I can't get my hand like that. It's great. We're going to go into a little bit of dorsiflexion, right? Oh, there we go. That's the way it should be. So now we're in dorsiflexion, but we're not really actively dorsiflexing again. This is the legs rolling through. So at this point, our plantar flexors are resisting our dorsiflexion. So they're eccentrically loading. Now we're going to start actively contracting the plantar flexors because we're going to start going into toe off. Right, so that heel's picking up, the leg's actually being picked up from above. We get to here, and that's where we're going to pick the foot up, right? So now we're here at toe off. The foot's going to get picked up, and what's the dorsiflexors going to do as soon as that foot's picked up? Are they going to actively contract? Yeah, they're going to actively contract to pull the foot up into dorsiflexion so that when we bring the leg through, we're not dragging our toes, right? Otherwise, we drag our toes. There is a lot going on in the foot during gait, right? All those muscles are being active, even the muscles of the toe, right? All those muscles of the toes have to be active. We've also got the inverters and everters that are stabilizing. If we're on a nice flat surface, right, they don't have much to worry about. But if we're on a surface where we might have some roll, now they've really got to control it, right? If you ever think about somebody walking on a really thin balance beam, watch how their ankles are kind of shaking as they go through it, because their inverters and everters are really trying to maintain that stabilization, right? Or a tightrope walker. There's a lot of stabilization going on at that point. I don't know why you'd ever walk on a tightrope, but I mean, I guess if you want to, sure. And then the intrinsics. The intrinsic muscles are really responsible for maintaining our arch through that whole motion. Even though traditionally we don't think of them being part of the arch, they are maintaining that arch so that at least it's functional. So that if we need to, suddenly we start losing our balance, we need a flat foot so that we've got some nice support. We can do flat foot, right? If we need to roll inward because the material we're standing on is rolling outward, we can roll inward. We can get that ankle planar support going on for motion. So areas of pressure and trauma for the ankle. The common fibular nerve is probably the most common one that you're going to have that has problems. It's lateral to the fibular head and neck, and then goes through the peroneus, longest opening of that down at the distal portion of the leg. And there's all kinds of reasons it can be injured, but the main reason is it's really superficial up towards the top of the leg. So it's really common for you to bang that, right? I often think when I'm looking at this common peroneal nerve, I almost think of it as our ulnar nerve of the leg, right? Because you can find your funny bone back here, even though it's not a bone, right? The funny bone is just the cubital area where the ulnar nerve passes through. Same idea if you think about it. That's kind of where what the fibular nerve does, right? And it's really easy to kind of bang it. Then you can get posterior tibial nerve damage or the tarsal tunnel syndrome, right? Where the medial area of the medial malleolus, and you end up with that posterior tibial nerve passing through there and getting compressed. This is just like what other syndrome in the hand? Right. So if I call the fibular nerve kind of our ulnar nerve, the posterior tib is kind of our medial nerve, our median nerve, right? So they kind of look together. And we have our plantar and calcaneal nerves. These can be compressed through overpronation. But all of this kind of ends up with, we can end up with nerve damage in the foot. If we end up with nerve damage in the foot, a lot of times one of the first things you'll notice is a collapsed arch. And I'm way down here. And we'll end up with that collapsed arch because, that went way too high. You end up with that collapsed arch because the nerves kind of go dead, and those intrinsics are kind of the first ones to kind of fail on us. When we look at the actual foot, the foot itself is usually innervated by primarily L4, L5, S1. So when you're having problems with the foot, that's where you've got to think of in the back, right? Why not S4, S5? Why doesn't S4, S? You would think that, just thinking about it, like you look at the foot and go, that's the most distal portion. That should be S4, S5. Well, not really. S4, S5 only innervates our perineal area, right? It's just what you would think that, oh man, that's our lowest part of our foot, so that would be innervated by the lowest part of our sacrosection. It's not. Because we're going to come back up the leg to get to S4, S5. But when you have this posterior tibial nerve syndrome, the tarsal tunnel syndrome, guess what it looks like? So let's see if I can draw a foot. There's big toe. 1, 2, 3, 4. That's a really badly drawn foot. So again, this posterior tibial nerve is over here on the medial side, right? By the medial malleolus. It comes down, swings under here. Well, guess what? You're going to have a symptom that looks almost like carpal tunnel syndrome, aren't you? Doesn't that look almost exactly like carpal tunnel syndrome? Yeah, right? And here's the funny thing, right? You bang off the common fibular nerve. Guess what? We've got out here. So that looks like ulnar nerve syndrome, or cubital tunnel syndrome, or canal of Guillain syndrome, right? Because that's going to eventually dive back here by the lateral side as well. So they just, the foot and the hand are not that far apart, even though they look completely different. Their structure and the way they function is pretty similar, right? So that's the thing. If you have somebody that's got cubital tunnel syndrome, if you ever run into somebody, you're at, not cubital tunnel, I'm sorry, tarsal tunnel syndrome. If you're ever at one of your clinicals and they're like, oh, this patient's got tarsal tunnel syndrome, you should just think, oh, well, that's carpal tunnel syndrome in the foot, right? And it even says it in it, tarsal tunnel syndrome, carpal tunnel syndrome, right? So don't be totally freaked out if you've got a patient that has that. So there's the tarsal tunnel. And again, it's just like the hand, right? There are so many ligaments and tendons that pass over that area. It'd be really easy for that nerve to get pinched down. And then when that nerve gets pinched down, you're going to lose sensation on that medial aspect of the foot. Guess how sometimes they solve tarsal tunnel syndrome? What do you think they're going to do? Yep, you probably do have a little bit of that. That's probably tarsal tunnel syndrome. Probably a little compression in that. So you need to stretch that medial kind of aspect of the foot. What do you think they might do if you need to have tarsal tunnel surgery? Almost like carpal tunnel surgery. So what do we do with carpal tunnel surgery? We talked about that. Yeah, they go off and slice off kind of some of the ligament, right? So the same thing can happen here. They can come in here, and I get my red because red is for slicing. And we could take a chunk of this ligament out. And that's going to open that nerve window. Right? And so if they open that nerve window up, then hopefully it relieves some of the syndrome, right? But look at that ligament that we might be cutting, right? That goes from our calcaneus right up to our tibia. So if you cut some of that out, that's also going to affect our stability, isn't it? And that's not unlike the hand again, right? We cut that ligament out in the hand and we can end up with the same idea where we lose some stability in our hand. So let's look at some common etiologies and problems, right? RA. So when RA affects the hands, does it affect the distal portion first or the proximal portion first? Does anyone know? Yeah, so it starts, well, technically RA starts proximal. It will work distal and make the distal worse. But the first thing people will complain about is like, I've got achiness. I'm not low enough here, right? They'll be like, I've got achiness in here in my palm. Well, guess what? When you have RA, same idea, right? Your forefoot gets affected first, then your hind foot gets affected. Now, the problems are usually worse on that, you know, the later portion where it gets out to the toes and the fingers like it does with the hand. So usually, right, the hand starts here across those knuckles, and then the fingers get affected and the hand gets affected. Same idea with foot. So that forefoot gets affected, the hind foot gets affected, the toes get affected. When those nodules build up, that's when the problem happens, right? Because when those nodules build up, that's when the hand starts gnarling. And they get a gnarly hand, man, right? But the foot, same idea, right? When you get those nodules in there, it's going to start curling the foot up. And now you've got a foot that looks like this. Is that going to be functional for gait? If you've got a foot that looks like Cruella de Vil's hand? No. General joint disease and joint trauma happens all the time. Ankle sprains, right? Ankle injuries, fractures, all that can come. We're going to talk about that in a few seconds. Post-immob stiffness, right, after prolonged shortening. So maybe you sprained your ankle and they put a brace on you. And you've been immobilized for 6 weeks, right? Now you come out of that and your muscles are short. Well, then you're going to be more susceptible to injuring the ankle again. Gout. How many of you guys have heard of gout before? Has anyone experienced gout? Has anyone had it? Gout is not very much fun. Yeah, big toe hurts, right? What causes gout? Does anyone know? Yeah, uric acid, which contributes from sodium. You're absolutely right, right? And what's a big component of gout in the diet? Rich person's disease, absolutely right. Yeah, sugar and also processed meats again, right? Specifically processed deli meats. And if you think about it, right? Oh, you learned it about art history, right? Lunch meat, yeah, exactly, right? Think about your lunch meats. What's their sodium count like? Usually. A lot of them are usually packed in salt water, right? If you get stuff like, if you go to the deli or whatever and they slice that fresh pack of, you know, Boar's Head, Virginia Tavern ham open up, the water that's in there is cured salt water. Right, and the why is that? Because, you know, the wealthy people could afford meats like that, right? You could afford stuff like pastrami and stuff like that, right? But, you know, for the cheaper people, it wasn't as available. So they're going to have to give them medicine to take care of it. Colchicine is typically the medication they give you for it, right? But the other thing is you're going to have to alter your diet. And this is a problem that I've got a pretty close friend that I deal with that has really, really, really nasty gout. He just gets gout constantly. And it's because he won't change his diet. Like, he won't stop eating processed meats. So, like, he's like, oh, I pay my gout tax. I get a good sandwich at the local deli in New York. And then for the next 2 days, I can't walk. Why? Cherries also work really good for helping this, believe it or not. I never would have thought of that, but, you know, like really fresh cherries, if you eat a lot of them. But the downside to that is if you eat a lot of cherries, guess what else is going to happen? You have a very functional bowel system. Swelling, right? Swelling at the ankle. Why is swelling such a pain in the butt at the ankle? Right? So if you sprain your ankle and you get swelling, why does it? Yeah, it's a lot of pressure, right? And there's not a lot of area for that ankle to expand. It's not like you have all this extra tissue laying around your ankle, right? You only have that if you have cankles. Then you've got some extra tissue down there, right? And we look at the feet a lot when we have all kinds of other diseases. Diabetes, we look at the feet, right? Blood pressure issues, we look at the feet because they are the most distal portion of our body and they tell us a lot about the patient's health, right? If you look down and the person takes off their shoes and their nail beds are yellow, flaky, falling off, that tells you they don't take care of their feet, right? And that tells you, right? And that tells you a lot about the person, because then you can think about, well, why does this happen? What is this? How does it equate out to the rest of their kind of function in life, right? Toenails. I don't understand why people don't trim toenails. I guess you ladies want it so that you can paint your toenails and look all pretty, right? But like the toenails are not specifically designed to help us walk. I'm just saying, they get in the way a little bit. So when we have any of the problems, obviously the maximum protection phase, we're going to decrease the pain and provide them with education. A lot of times the idea if we have an ankle injury is rice. We need to get them to rest it. We need to get them to ice it. We need to compress it and elevate it, right? And then protect, if you want to call it price as well. And with the ankle and even with the wrist, because the wrist and ankle kind of go together, we want to make sure that this will be one where we do tend to rest a little bit more than the rest of the body. Just because there's not a lot of space in that area. And if we re-injure that area while it's already injured, it's going to prolong the injury more than it would shorten it for taking a little bit off. And let's face it, the muscles in the foot and the ankle are not as 100% viable as something like a quad, a biceps, a hamstrings, where if we immobilize those muscles, we lose a great amount of function. We can get back to the function of the foot if we immobilize. That's kind of what I'm saying. Maintaining joint and soft tissue mobility. This is like a big area, especially in the casino workers here, man. I just see them all the time coming in when I was in the clinic, coming in with all kinds of foot and ankle injuries. Either from poor footwear when they're in the actual casinos to, they come around a corner and a client, another customer is coming around the corner and they have to stop and they end up rolling their ankles. The floors in casinos, they're not exactly designed to help function of the foot, right? A lot of the floors in casinos are really, really hard, right? A lot of the floors in the casinos often, make you look at Costco and go, man, Costco seems like a really comfortable place to work. Or the other side, right? You go into some of those casinos and they have the carpet where you walk on the carpet and you sink 9 inches into the carpet and you're like, oh, this feels luxurious, right? For you guys that are going to the casinos, not a bad problem because you're only going to the casinos for an hour or 2 hours until you lose all your money and cry. The casino workers have to work on that floor for a whole day, right? Let's think about some of those servers that might be wearing something like high heels. And now they're working on floor that has, a 2-inch squish portion. Is that going to make gait more difficult? And guys, just say yes. I know you've never walked in heels, or maybe some of you have. I'll say, like I did, got a new appreciation of what high heels are like back in Pennsylvania. We did there was a walk for violence against women. And it was called Walk in Her Shoes. And so guys, I signed up for it and a couple of my buddies signed up for it. And the goal was to walk 5 miles in women's shoes. And man, I'm sure there are videos of it somewhere, but oh my God, it is the most hilarious thing in the entire world. Yep, we got to wear heels. And first of all, like they had a bunch of people there and they're like, okay, so let's find a shoe for you. Finding a 10.5 4E heel exactly doesn't happen, right? I'm a 4E almost on a 5E in my foot in width. So we basically had to squeeze my essential ham hocks into a size smaller shoe. And it was kind of, no, there were no picks that day. Absolutely not. Nope. But what it did make me appreciate, especially from a physical therapy standpoint, was because we raised money for charity, obviously. What we learned was, what I learned is walking those shoes is not easy. I had a new respect for the way women walk in those shoes. I also understand that now men probably design them and they need to go away. Because man, for the first, half a mile, yeah, not too bad. I was like, I don't understand why you were complaining about this. Got a little bit further and it started to suck. And then I got a little further and it sucked more. And then at some point, I just felt like I was killing my feet. And the best part about it was they said that if you broke your heel, you had to keep walking with the broken heel. So my buddy ended up rolling his ankle and broke the heel off of his shoe, and he had to walk the last 2 miles in one foot up like this and one foot like this. It was amusing, but yeah, right? But why? Why do you have to wear them for interviews? Just curious. Think about that for a second. And exactly, why is that standard set? That's kind of where I'm going with it, Erica. Is I'm not judging you, right? Why is that? It 100% is, Kelly. I hate to say it, right? Because a guy who, there is an impression on that, though. I'll give you, coming from an interviewer standpoint, right? I don't know why. Why does that make a woman look more put together? Because I'm going to be honest. If you talk to a bunch of interviewers, do they look at guys' shoes when they come in? I actually do. I take a look at guys' shoes when they come in because it tells me about the level of care they have for their dress shoes. And the level of care that a person puts in for their dress shoes, and even Michelle will agree with this, one of the things they teach you in the military is you take care of your boots, right? They've got to be spit shined and blah, blah, blah. Somebody comes in for an interview, I actually look at their shoes, so I want to see if they're taking care of them. Right? It tells me a lot about the person. I may be one of the weird people that actually looks at guys' shoes. I don't care if you're wearing heels when you come in for my interview, to be 100% honest, because the only thing I'm going to look at is, are you wearing sneakers? And now in physical therapy, I actually look at that as a plus. If you're coming in sneakers to an interview, you're ready to work. And I've actually, in my older age, have gotten out of even dressing up for interviews. I just don't. When I interviewed at Pima, I came in a pair of scrubs. Now, granted, I was leaving the hospital coming in, so I kind of warned them in advance. But if you're not going to hire me for my qualifications, why should you hire me for the way I look? I don't know. Just weird. Sorry, I'm going off on a tangent there. But no, yeah, there were a couple guys that walked way too good in walking heels. I agree. Yes, there were. A couple of my coworkers walked way too good in those heels. Just saying. They were really good at it. I was not. I kind of looked like, have you ever seen a bird the first time it gets out of the nest and it's wobbling all around? Or the new cow when the cow first stands up. That's kind of what I looked like. It was amusing. So once we get back to this controlled motion phase and return to function, right? Even looking at these casino workers, well, now we can start getting some mobilization techniques to kind of move those joints around and function them, right? And then we're going to try to improve that joint tracking, specifically plantar flexion, dorsal flexion, because a lot of patients will kind of lose some of that. They'll lose some range of motion. So that's why we're going to have to measure the range of motion of the ankle, make sure we get that inversion, eversion, plantar flexion, dorsal flexion. We don't really care so much about that abduction, adduction. It's not necessarily as hard for gait as plantar flexion, dorsal flexion, inversion, eversion, because that foot's got to have functional motion to do stuff. We'll increase the mobility of soft tissue and muscles, meaning we're going to start doing some soft tissue work. And Tyler will tell you, doing soft tissue work of the foot is a unique experience because a lot of people both hate and really love their feet getting worked on, right? You can either have somebody that they want you to destroy their feet, or every time you touch their feet, they giggle like a little kid. But in physical therapy, we have to, a lot of times, work on that soft tissue, specifically the plantar aspect of the foot. So what if you have somebody that's really ticklish? So what if you have one of those patients, you need to tear at their soft tissue a little bit to kind of break up some of the adhesions. But they're one of those people that as soon as you touch them, they start giggling like crazy. How do you overcome that? What are some ideas? Try to distract them. Good, right? That's the idea, right? So how do you distract them? Any ideas? Yeah, conversation works. I usually give them something to read if I can, right? But also deep pressure works really well, right? Yep, exactly. Don't use light hands. If you're like, tickle, tickle, tickle down your foot, the person's going to kick you, right? But you can put a little bit, and I tend to do that a lot of times when I'm working with somebody that's very ticklish. I'll often use my other hand and squeeze somewhere else. So maybe if I'm working on the foot, I'll go up to the calf and give a good squeeze to the calf, right? And we know that if we squeeze the calf, we'll get that plantar flexion going on, right? So if I squeeze that, they're focused on it. What I'm really using at that point is gait control theory, right? I'm putting pressure up here to stop them from feeling me kind of working with the foot. Sometimes you have to use tools. Some people just can't handle a human touch. But if you break out something like a scraper or an IASTM tool, they're okay with that. And then there's just those people that no matter what you do, they're going to sit there and giggle the whole time you're working on the feet. You just deal with it, right? Try to control their foot. Don't control it so it breaks, but control it and work that soft tissue. A lot of you, I guarantee if we started messing around with a lot of your soft tissue on your feet, I'm guaranteeing most of you have some soft tissue issues in your feet. You probably have a little bit of plantar fasciitis, maybe some bind down points. We can probably find trigger points on everyone's feet. Then we got to work on balance. Pretty much anytime we're working the ankle and the ankle mortise, we've got to integrate some balance stuff. So maybe some single leg balance, some double leg balance activities. And we got to improve that idea of where the ankle is in space. You may start with them watching their ankles, right? So I want you to look down at your ankle and I want you to see where it is in space so they can see how their ankles are moving. But eventually you have to get them to stop watching their ground so they can focus on sensing the ground, right? And even in the martial arts, we do this a lot where, we want to take away the sense of sight so that we can listen more to what our body is telling us. Because if you can do that, there's all kinds of theories behind that. But anyway, if they can listen to what their ankle is telling them, they'll be better at interpreting having problems in the future. And then cardiopulmonary fitness goes right along with ankle issues, right? Total ankle arthroplasty. This is a thing. It's usually only indicated for somebody older than 65. And they've got to have a low BMI. What's BMI? What's BMI stand for? Body mass index, right? So that means they've got to be thinner. They've got to have a low pre-surgery ankle injury. So they've got to have that ankle pretty well torn up. And then usually they're going to be a sedentary person for this. And this is weird. This is different than something like the total knees and total hips, where we're going to want them to be more active, right? But a sedentary person for an ankle is actually a good thing because the total ankle replacement or total ankle arthroplasties aren't as functional as our total knees and our total hips. We haven't gotten these yet, right? A lot of them end up with chronic infections of the foot. Why might they end up with infections in the feet? What do you think they're getting on their feet? Sores, ulcers, right? Yeah. So who's likely to get ulcers of the feet? What population? Older, and what condition? Yeah, diabetes mellitus, right? And oftentimes they end up with ulcers because they don't feel their feet, right? So the ulcer starts off innocently enough. Yeah, it's numbness, right? So, but then say little Jimmy, their grandson, thought it'd be funny to put a one-piece Lego inside grandpa's shoe. You know what a 1x1, you know what a 1x1 is? Right? Tell me kids don't do this though. I'm sorry. I've had kids put things in my shoes and I don't even have kids. Right? For us, we put our shoe on the first time we plant down, we're like, son of a, I'm going to get the kid. And then we take the whole box of Legos and dump it in their shoes. Maybe that's just me. But when you have somebody that's got diabetic neuropathy in that foot, they may not feel that 1x1. So now they're walking around all day. Maybe now, you know, grandpa goes down to Sam's Town to pull the one-arm bandit for 8 hours. And he's down at Sam's Town walking around. He's seeing all of his buddies. You know, they're hanging out. They're smoking stogies. They're walking around. They're getting food that's probably bad for them. They go to the buffet. And they get some Corona going on. And he comes home and he takes his shoe off. And all of a sudden he takes his shoe off, and this is a real old man. He probably has dark socks on, but we're going to pretend he had white socks on. Takes off his shoe, and he looks at the shoe, and the shoe's got a blood stain in it. And he looks at it, well, that's interesting. Takes the sock off and doesn't even think anything of it. Because if I can't feel it, it can't be anything big, right? But now we've got an open wound, right? And it probably sat in his shoe for 6 hours. Yeah, so now we start getting infections setting in, right? And we could end up with a fungal infection, right? Where maybe he has some athlete's foot and now that fungus, right, got into the shoe. I told you about the mushroom going to the bar, right? Did I tell you that joke? That a mushroom walks into the bar and the bartender says, "Get out of here, we don't serve mushrooms here." And the mushroom's like, "Hey, why not? I'm a fun guy." I'm just full of them, man. Dad jokes galore. But yeah, so now, you know, we'll call him Milner, has a sore on his foot. He doesn't really take care of it. Keeps putting his shoes back on, doesn't put a bandage on it, right? Doesn't create that closed, moist environment for it to heal. Now it gets infected. There's not a lot of tissue between the inferior aspect of your foot and your bones. So now that infection gets into the bones and he gets an osteomyelitic infection. Now he needs this ankle replacement, right? Or if he doesn't get the ankle replacement, maybe he needs an amputation, right? So there's all kinds of implant designs, material fixation. Most of the time, the implants are just like the total knees and total hips. They're going to be titanium. But overall, the problem with this surgery is it's just not as functional, right? And why is it not as functional? Well, let's think about it. What if we had to replace the top of the talus? Because that's what we're going to do. They're going to replace the top of the talus and the distal aspect of the tibia. Think of all those ligaments we had in that picture a little bit ago of the ankle. Is it going to be easy to get into that talus? No. Right? So that means they've got to cut all those structural ligaments out. And, you know, the old way we'd do that is we just fuse it. Just fuse their ankle and be done with it. Now, these arthroplasties exist, but, man, they're just not as good. And then most of the ones that I've seen, and I've probably only seen a total ankle arthroplasty maybe a dozen times, less than 20 for sure. I'd probably say 50% of them led to an amputation later down the road. So I'm just curious, like, if you know it's going to lead to an amputation down the road, I don't know. I think I'd probably just go with getting the foot amputated and learning how to use a prosthetic earlier on when I'm functional than when I'm old and I can't do it, right? I don't know. It's just an interesting thought process. If we have this total TAA, right, most of the time they're going to be immobilized, and this could be a long time. The one guy I saw was immobilized for 16 weeks. He was immobilized for 16 weeks and toe touch weight bearing on that leg for 16 weeks. Whew. You want to talk about losing all function in the leg? That's a good way to do it. Right? So we had to do tons of other stuff. You know, even if the ankle is immobilized, It doesn't mean we can't do stuff like long arc quads, quad sets, glute sets, ham sets, heel curls to keep the leg itself patent while the ankle heals. So that's what a lot of times these patients are going to be doing when they have this total ankle arthroplasty. We're not even going to be working on the ankle, at least in that maximum protection phase. We're going to be working all the associated musculature so that because they can't put weight on that ankle, the rest of it doesn't happen. Pain relief. Good news is the ones that I've seen with TAAs, most of them don't have pain anyway because they're diabetic and they've got neuropathy. So they come out of the surgery and they don't have a ton of pain, but it also then reduces their protective nature of that foot, right? They don't think about it as much using it. But let's think about this for a second. So maybe I have some deep proprioception in my ankle because I still got some bone sensation, some pressure in my diabetic foot, but I don't have sensation in the skin. Well, now I take out those sensations of the bones and those deep baroreceptors. Now I'm all over the place with that ankle. Just because I didn't think about, oh my God, yeah, you take that out and I lose a bunch of my stuff. And then participation in physical activities, man, it's going to take a while. I don't really like TAAs, but I've seen only a few of them. Here's what TAA looks like. Does that look very functional? I don't think it does. Right? I look at that going, ugh. Like I could probably design 50 different ways to do that. Why does it not have a roll, right? Why does it not have a natural curvature like we would normally have? Well, again, that's because most of the time we don't care about that. All we want is minimal motion going on in that ankle after surgery, right? But man, that ankle does not look functional. Arthrodesis. When you hear arthro and desis, what does that mean again? Arthrodesis. Not joint splitting. The opposite of a split would be to fuse, right? Desis is a fusion, right? So an arthrodesis means we're actually going ahead and fusing the ankle. Most common that you'll see of the arthrodesis of the ankle is the hindfoot. It's called a triple arthrodesis. This was really, really common in the 50s and 60s because this is a typical polio surgery, right? And if you've ever seen a person with polio, Google some videos of them. They often don't have a lot of muscle mass in the legs, and so the ankles fail very commonly. So they'll fuse the subtalar, the calcaneal cuboid, and the talar navicular joint so that that ankle is a solid mortise. It gives them a stable surface to stand on, but man, not functional, right? So a lot of them have a functional standing posture, but they don't have a functional gait anymore. And the thought process used to be for polio patients was eventually they're going to be in a wheelchair anyway, so it doesn't matter, right? Little did we know that eventually we'd come up with, oh God, my brain just melted on me. Hold on a second. That we'd come up with a vaccine for polio. And now we have a vaccine for it, right? But hey, we're bringing polio back. Go America. You can get an arthrodesis of the first toe, fusion of the first toe. What might cause you to get a fusion or surgery on the first toe as well? What other type of things might cause you to get surgery on the big toe? What's the other surgery that's common on that big toe to have removed? Funyuns are what you eat, but a bunion's what we remove. Right, bunionectomies. I think I've got that coming up here. So with the arthrodesis of the ankle, again, the downside to arthrodesis of the ankle is it's going to be fused. They lose long-term function of that ankle. So they're going to fuse them in about 20 degrees of dorsiflexion so that they've got clearance of the foot. And then after that, that's where they're going to be forever, right? Again, most of the time, if they do these arthrodesis, they know the patient's going to end up in a wheelchair anyway, so they're not as concerned about it. But it's going to remove their function, right? You're not going to be walking around chasing people around on your feet all day long. Other problems we have, heel pain. Does anyone suffer from this, where you get heel spurs or heel pain a lot? right? So oftentimes it's usually caused by plantar fasciitis. It's usually the start of plantar fasciitis. Oh, so it is. That's what yours is caused by? Yeah, right? You can also end up with Achilles tendinopathy or Achilles tendonitis, and it's usually through the mid portion of the tendon, but that's just from overuse again. Again, ladies tend to get Achilles tendinopathy or tendonitis from wearing high heels. You can get tendinosis, tendonitis, tendinosynovitis, or any of the extrinsic muscles of the foot. So any of those muscles that start in the leg, you can get tendonitis, tendinosynovitis on them. Again, when you see tendonitis, tendinopathy, tendinosynovitis, you've got to be thinking overuse injury. So if they have an overuse injury, we have to learn how to minimize whatever they're doing to reduce that overuse. Anterior shin splints, overuse of the TA, pain increases with active dorsiflexion and passive plantar flexion. Posterior shin splints are usually caused by triceps surae, pain with passive dorsiflexion, eversion, or active supination. So this is how you can tell whether your problem for shin splints is an overactive TA or an overactive triceps, because usually when you have shin splints themselves, they just hurt in the shinning. It's really hard to determine what's causing it. Well, this is the way we can kind of look at it and go, okay, is this more TA or is this more posterior shin splints? And it's just by doing stuff. So we'll have them actively dorsiflex. If the pain gets worse, it's tibialis anterior. If pain's fine with active dorsiflexion, then we'll move on and go, okay, how about if you actively supinate the foot? And they go out and supination, oh my God, that hurts. Well, now we've got a problem with the actual posterior aspect of the leg. For plantar fasciitis, going back to this real quick, what are we going to do to treat that? How are we going to make plantar fasciitis better? First of all, can we make it better? Yeah, we can, right? We can get shots for it. There's all kinds of things we can do, right? We'll take shots. No? Okay. For physical therapy, what are we going to do? Manual massage, a lot of, right? We're going to work the intrinsics. Remember those toe squeezes we did? We're going to do a lot of those. We're also going to work the extrinsics. So we're going to have them doing a lot of ankle exercises. One of the big ones we're going to have them do is ankle alphabets. Anyone ever seen somebody do those before? Right? Yeah. Oh, God. I was like, oh, God, no. And ankle alphabets, we're having them draw in the air the alphabet, right? You really want to make them confused. Ask them to draw in cursive. Because today's day and age, no one knows what cursive is. We may also do contrast baths. Does anyone know what a contrast bath is? We talked about it when we were at UNLV. Yeah, going from hot to cold, right? So, we may, depending upon if they're in acute or chronic phase, will depend upon if we start, yeah, right? We're dependent upon if we're in an acute or chronic phase, will depend upon if we start with hot or cold to kind of get things going, right? If we have a lot of swelling down there, we may start with some, cold to get it kind of pushing away, and then some heat to loosen it up, then some cold to, it just depends upon what we're looking at. But my big thing is if I'm doing contrast baths, I'm really being mean to my patient because they're going to be doing ankle alphabets while they're in contrast baths. So while they spend 3 minutes in the cold, they're doing a full set of ankle alphabets. Then they're going to go over to hot, and they're doing another full set of ankle alphabets. Wobble boards. Wobble boards are probably the least things that patients hate, and we'll get one of those out when we get into lab. With the wobble board, the goal is not to make the wobble board slap back and forth on the floor. That is not the point of the wobble board. Although that's what the patients think the point of the wobble board is to just sit there and smack the sides off the floor. The goal is to be able to roll the wobble board all around and not touch the sides and not make any noise. But yeah, a lot of manual therapy. We may do some ultrasound even, or even worse for plantar fasciitis, we'll get out the pneumatic compressions or slamming on it with, yeah, I'm drawing a blank right now. My brain's not working. I think we're going to need a break here soon. How many more slides do we have? Yeah, let me see here. Yeah, we've still got a break. All right, let's take a 10-minute break because my brain's starting to melt and I need some caffeine. me get up my timer here. I just realized all of a sudden my brain just shut down for whatever reason. And if my brain shut down, I know your brain shut down. All right, let me pause this recording here, and then we'll get into talking about some plans of care. All right, so we had talked about, we finished last time just kind of talking about just some of the common, honestly, soft tissue injuries of the ankle is really what these are. Again, protection is going to be the key. If a person is having plantar fasciitis because they're wearing heels all day, what should we probably consider doing? Telling them to do what? Yeah, not wear heels, right? At least for the time being until that repetitive injury calms down. But what you'll find out very frequently is people that get these soft tissue injuries to the feet, they just keep coming back. The foot is one of those that once you get a problem down there, it will nag you for the rest of your life, right? I've got plantar fasciitis, and it's usually only my left foot. And I don't know why it's only my left foot. I think it's because of my short leg. I don't know. It really irritates me. But when I get it, it comes back with a vengeance and is angry. And I'll work on it. It'll go away, and it'll be 9, 12 months, and then it'll come back. It's because a lot of these injuries are those repetitive use injuries, and it's from something I'm doing that's causing it. It could be from doing the martial arts. Could be from, walking on the treadmill. Could be from getting on elliptical. Who knows, right? But the main thing is we need to educate the patient, provide them some home exercise. Stretching. We really need to get patients to stretch out their calves. That is probably one of the biggest things. The same thing when we talk about, like when we have carpal tunnel syndrome and problems with the palmar fascia, one of the things we're going to do is stretch them into extension because that relieves a lot of it. Same idea here. We're going to stretch the patients into dorsiflexion because it really does help with plantar fasciitis. You can kind of lengthen out that plantar fascia. It'll kind of suck it and snap it off those adhesions, which help things. And then improving muscle performance, ultimately strengthening the whole leg, right? So here's kind of looking at this stuff. And again, this is why I said, if you have to do a total ankle replacement, look at all those ligaments you're going to lose. That's just a hot mess. But looking at that also looks at why it's so easy to get a sprain, right? So ankle sprains. Which is the most common ankle sprain, an inversion sprain or an eversion sprain? Right, inversion sprain is the most common. So one of the things you're going to have to understand when you get sprains of the ankle is the position of comfort. So when it's talking about a sprain and the question asks you about the position of comfort for this is, your position of comfort is going to be the opposite of what caused you to get the sprain. So in the case of an inversion sprain, usually an inversion sprain is going to go into inversion and plantar flexion. So then what would be the position of comfort? Eversion and dorsiflexion, right? So now if I do an eversion sprain, the eversion sprain, which is less common, is going to be everted and dorsiflex, which means the position of comfort would be, plantar flexed, inverted, right? That would be where we're going to splint them or put them in for the protection, the rest phase of the ankle sprain, right? So we're going to kind of move them in, if they're an inverted sprain, we're going to move them into that little bit of dorsiflexion and definitely eversion. We don't want to hold them there forever because obviously they'll weaken, but that's the position. So let's say you've got a patient you're seeing in the outpatient clinic that has an inversion sprain. You've worked them through all the exercises, and now you're going to put them on ice. You probably want to put them into the position of comfort to ice them. Now, they can rest in neutral. That's okay. But the better option would be to find a way to put them into that everted and dorsiflex phase to help with pain management. And if you do that on top of the ice, it'll actually help the pain a lot more. So think about that when you've got sprains, right? It's just like if I have a bicep sprain from overextension, my position of comfort is going to be flexion, right? And if you've ever seen somebody that's injured their bicep, a lot of them walk around like this, right? Because this puts them in a position of comfort where they're not worried about straining that anymore. Same thing with the ankle. The position of comfort is where we're not going to re-injure the injury. Re-injure the injury. That's good. During the protection phase, though, right? The ice is important. How long do you ice for? 20 minutes or until numb, right? So this is a big thing that new clinicians make the mistake of doing, because they'll just ice for 20 minutes, right? We want to do 20 minutes or until numb. If the patient gets numb at 5 minutes, that's it. You're done with ice. You don't need to keep them on for the full 20 minutes. They're not going to get more of a result staying on for 20 minutes than they would have got just getting to the numbness. You might get a little bit of swelling reduction, but not much. When you get that numbness phase, the body's already pretty much maximally vasoconstricted. So 20 minutes or until numb, right? And then how long do they wait before they do it again? So at least, ideally, I'll tell my patients at least 2 hours. The reason I'll tell them 2 hours is because if I tell them 2 hours, they'll do it in 1. You can do 20 minutes on, 20 minutes off is a common thing, but most of the time, if you're talking about that price where you're protection, rest, isolation, or protect, rest, ice, compression, elevation, you've got the compression to go along with it. So you don't necessarily have to do 20 on, 20 off. But I usually tell them 20 minutes on every 2 hours. Then I know they're going to do it probably 20 minutes on every hour, hour and a half. But you've got to allow the blood flow to return. If you do the 20 minutes on, 20 minutes off, it may not be enough time to allow blood flow to fully return to the area. Right? And the other problem is you can end up with crystallization in the actual distal arteries, in those little capillaries. So you got to be really careful that we don't totally freeze it. Doesn't hurt. Again, a healthy person, 20 minutes on, 20 minutes off, not going to be a problem. Most of us are healthy. That's not going to affect us at all. But when you get something combined with like diabetes or blood pressure issues or stuff like that, that's where we've got to be a little bit more careful and a little bit more protective of our patient and kind of say, okay, maybe for the athlete, 20 on, 20 off, good, right? And that's the thing, most of you guys are 20 on, 20 off because you've been in sports, right? Probably most of you have done an ice tub before at some point if you've been in sports, and that is the most miserable experience that you will ever know to man. I don't care what you say. It does not feel good. It is miserable. And I like cold. I think ice tubs are miserable. Again, bracing, good, but with limits, right? So what if a patient is sitting down with their leg elevated? Do they need their brace on? What do you think? So they're sitting down watching Judge Judy with ice on? No. Give the foot room to breathe, right? That's what when I grew up, they always talk about giving stuff room to breathe. Give stuff room to breathe. They don't necessarily need it there. They need that protection when they're up and moving. It's a lot of like low back braces. It's a lot like, slings and stuff like that. A lot of times those braces and those orthotics and orthoses are going to be specifically for when out of bed or when moving. So, the problem becomes when the person becomes completely dependent on those braces. And where's that brace 24/7, 365? And usually at that point you can tell because the brace is really nasty. I've seen ankle braces that are white when they start with us, and then by the time they're done, they're yellow. Lateral ligament tears happens, especially in inversion sprains, right? They'll usually only do surgery if the tear is complete. So what would be the rating of the tear? Remember we talked about the 3 levels of rating. What would be the rating of a tear if it's a complete tear? It would be a level what tear? Level 3. Good. I gave you a hint, right? 3 levels. It's the level 3 tear. At that point, then they can start considering surgery. And understand, level 3 is not always full tear. It can be a mostly complete tear as well. But if you've got something like that lateral ligament hanging on by one thread, probably want to fix it, right? That lateral ligament's going to help us with stabilization. Again, they can do all kinds, just like any other surgery. They can do repair with augmentation. They can do arthroplastic. They can do a capsular shift. The main idea for us is it's not going to matter what type of procedure they do. It's going to matter on how we treat it. And we have to think about that. If we have a lateral aspect tear, that means we've rolled inverted. That means we need to strengthen those everters to keep us from going into inversion, right? So we need to strengthen those peroneal groups to keep us from rolling our foot so much. That's when you're thinking about this. How do I prevent myself from rolling my ankle inwards? I've got a chronic, like I said, my left foot's the problem again. I chronically roll my left ankle, right? So in order to overcome that chronic rolling, I focus heavily on everting that foot and strengthening as much as possible so that I can help keep it from rolling as much. Same idea here. Our goal is to protect the surgical site if we can. Ruptured Achilles tendon tear. Oh, this is bad. Think about that for a second. A ruptured Achilles tendon. That doesn't sound like fun, does it? Right? And Achilles, most of the ones I've seen like this where there's been a rupture, it's been an avulsion tear. And what's an avulsion tear again? Talked briefly about this before. Yeah. They are gnarly to watch in slow-mo, you're exactly right. What's an avulsion tear? When you hear an avulsion tear of a muscle, it means the muscle pulls a chunk of bone with it. That sounds great in the heel, doesn't it? So if you tear that, they're going to have to go back in and do surgery. And there's all kinds of protocols out there, whether you do, again, it says primary versus delayed repair. Some surgeons will say that they're not going to do a repair to that surgery site for several weeks because they want the inflammation to kick down before they actually do the repair and the replacement. Some surgeons say it's good to get in right away. Like, you know, they come in, they come to the hospital, they've got an avulsion tear, they should be in surgery within a couple hours. It's all going to depend upon the protocol of the surgeon who does it. What they're going to do is they're going to go in, and if it's just a partial tear, they'll pin it. If it's a full tear, they'll go in and they'll really pin it. And they're going to do an a plasty where they actually reattach that tendon to the calcaneus. But let's think logically about this. Again, if we have to put pins in and repair those bones or repair those tendons, are they as strong as the previous tendon was? No. And they're also now more likely to rip back again, right? So it's pretty rare. I mean, it is pretty rare that if you have an athlete that gets a full calcaneal ruptured Achilles tear, it's pretty rare for them to get back to sports. Now, if you say, well, I know an NBA player or I know a football player that went back to sports, yeah, you might have seen that on television, right? But you got to remember those people that play, yeah, right? Those people that play at that level, not only are they the peak physical specimen for what we have for those sports, right? They've also got access to doctors that we don't have access to, right? I think about, you know, I think back when Adrian Peterson played for the Vikings, right? Adrian Peterson played for the Vikings. One year he tore his ACL. He came back the very beginning of next year, and guess what he did? Tore the other one. But he was back in like 9 months playing. How was he back to 9 months? Because number one, right? Yeah, exactly. Number one, they're able to get back to it because they have access to immediate surgery. If you tear your ACL, how long is it going to be till you get surgery? What do you think on average? Excuse me. Yeah. On average, on a good term would be 2 months, right? About 8 weeks, right? Because now think about it. You tear your ACL, you probably went to urgent care, Urgent care did an MRI on you, maybe if you're lucky. If not, they probably what happened is you went into urgent care and urgent care said, oh, here's some Tylenol, go home, take some Tylenol, go see an orthopedist. To go see an orthopedist, you got to go see your primary doctor in order to get a referral a lot of times, right? So you get that referral to go see your orthopedist, then it's bouncing around in merry hell trying to find an orthopedist that's going to take you, right? Because maybe they don't take your insurance or maybe just everyone's booked up. So then finally you get in to see an orthopedic doctor and the orthopedic doctor's like, well, I can't do surgery until I have an MRI. So now you got to schedule an MRI. You get that MRI. Then you've got to wait for it to be read and sent over to the doc. Then the doc's got to read it itself. Then you got to get back in to see the doc. So 2 to 3 to 4 months till you get surgery. You know, Adrian Peterson was in surgery that night. That's the difference between, you're right, exactly, right? That's the difference between, honestly, the haves and the have-nots. I hate to say it. But the other thing is, why did he get better? So, and same thing, why did Kobe get so much better? They moved physical therapists into their house and were getting 8 to 12 hours of physical therapy a day. Right? If I give you 8 to 12 hours of physical therapy, do you think you're going to get better faster? For sure. Right? Let's think about it. Like, say we've got a patient that's a stroke. And instead of worrying about units, we can spend as much time as we need with them. 9 months for, jeez, criminals. Right? Let's think about it. Like, yeah, it's amazing how long it takes, isn't it? But let's think about it for a second. Like, tomorrow, one of your family members has a stroke. And in I walk as the PTA after the PT's eval'd them, and I'm like, look, I'm your mom's PTA. I'm going to be seeing her all day long. So we're going to do a little bit in the morning for a couple hours, then we'll do some more in the afternoon, and probably in the evening we'll do a little bit more. And your mom's getting, 7 hours of therapy a day, and she's my only patient. Do you think that stroke's going to get better faster? Yeah, right? But we don't do that, right? That's not something the average person gets. The average person just doesn't get that much therapy. The average person can't call an orthopedic doctor and have them come over to their house, right? Because it said retina repair. Was that Erica said retina repair. Can you imagine calling up an ophthalmologist, Erica, and saying, hey, can you come over to my house today and check out my retina? I know, but I'm just saying, could you imagine calling up and they're like, yeah, sure, Eric, I'll be right over. What do you think if Evander Holyfield, thought that he had a retinal detachment? Do you think the doctor would show up at his house? I bet he would. Right? There's a different type of healthcare. Yeah, well, same idea. When I broke my neck, the surgeons I finally get in to see the orthopedic surgeon. He's like, you really should have had the surgery about 4 months ago. I'm like, yeah, no, shut up. So you got to think about that. And this is a debate even among surgeons. Does the surgery need to happen right away, or does the surgery need to happen later down the road? And I'm of the opinion that the sooner you can get the surgery, the better. It's my personal opinion, again, from what I've seen. If you need surgery, the sooner you get it, the better the outcomes, because you don't have a process to build in bad habits. Yeah, absolutely. Well, it can be, right? Let's think about it. What could be genetic? And maybe not be, the ruptured tendon may not be genetic, but they maybe have a predisposition to having, over tight Achilles tendons, right? There's a predisposition to having tight muscles and like familial lines. So it might be the way, maybe both of them have a very similar gait pattern too, right? And it's crazy. Or maybe do they do similar work as well? No? Okay, well, that rules that out. So then, yeah, probably it has something to do with genetics and the way their muscles are designed. I'd be willing to bet it's not only the gastrocs that are problematic with them, but it just happens to be that's the one that ruptures, right? And that's why we have that Thompson test. So again, ruptured Achilles tendon, usually for the most part, we used to do immobilization again. And again, with all total knees, total hips, total ankles, total shoulders. Our old approach would be immobilize, immobilize, immobilize. We are learning more and more as life goes on that that approach is bad. That early mobilization is better because we lose less. But you'll still have those doctors that say, you know, nope, they're going to be immobilized for 6 to 10 weeks. And patients are like, man, I want to get back to doing stuff. And you've got to say, surgeon says we can't. Even if you know they're ready to go back to maybe walking or something like that, you've got to stick to the surgeon's protocol or it'll become ugly. Ruptured Achilles tendon, non-operative versus operative management. For the most part, again, what I've seen and what the book shows is that there is a better outcome with operative management with this than non-operative. And that kind of makes sense because the Achilles tendon is pretty important to gait cycling, right? They can do either open or percutaneous, meaning an open versus an arthroscopic procedure. I've usually seen better results, again, from arthroscopic procedures just because they don't have as much opening. And then again, traditional versus accelerated rehabilitation, hands down, what I've seen nowadays is accelerated rehabilitation causes the patient to get better faster. It just makes sense. And again, we'll do some ankle exercises here when we get into lab. So let me switch to screen sharing here. So let me bring up, so we're going to look at some plans of care here and look at some evals and kind of talk through them so that you guys can think about how to do it. So let me share screen. I've got a patient sample scenario here. So let's look at this patient here. All right. So we have our patient here, Hal, right? Patient's a 37-year-old male who's 2 weeks out of a right shoulder arthroscopy. And he's being seen in outpatient. So just because he's being seen in outpatient, we know at this point that the patient's already been through inpatient. He's seen inpatient. He may have, 2 weeks out, he didn't go to rehab. So he's coming to see us. So this is an example eval. This is kind of what you're going to look at when you look at an eval. Now, here's the deal. This is a simplified eval. Real simple. A lot of the other evals are going to be a lot more complex, and there's a lot of information to them because they may have the dash, they may have the oswestry that you've got to look at. As a PTA, don't get tied up in the eval. You can spend a ton of time reading all of this stuff, and it'll just bog you down, right? We don't have time to look at everything in the eval. We do have time to look at the important stuff of the eval. We need to know what we need to be safe-wise with the patient. We need to know our restrictions. We need to know what the goals are. But let's look. So this patient has decreased range of motion, decreased generalized weakness, lack of normal mobility, inability to perform ADLs, pain with activities, specifically with overhead reaching. And then obviously if he has pain with overhead reaching, he's got decreased ability to perform ADLs, right? The next section usually of your eval is your PMH. What is your PMH? What's PMH mean? Past medical history. Very rare do we see this anymore. Past medical history, unremarkable. Basically means what? What does unremarkable mean? Yeah, not much going on. Nothing important doesn't note. Nothing important to note, right? So overall, this patient's healthy, all right? Social history is important to understand because we need to know what he's going back to. The patient is an ex-Air Force pilot who works for a testing facility outside the city. Resides in a single-story family dwelling north side of town. No stairs to enter and no stairs in the home. The patient enjoys cross-stitch patterns in his downtime. Would a right arthroscopy interfere with his pastimes at this point? What do you think? Is it going to interfere with cross-stitch? Is that shoulder surgery? Has anyone ever cross-stitched before? Yeah, it's going to, right? Because he's going to hold his shoulder here to cross-stitch, right? It's going to be tight. Is he going to be able to fly planes? Probably not. Depends. Depends on what kind of planes you're talking about. If it's something like a Cessna, he may be able to, right? So just looking at that, before we go down and look at anything else in this eval, you've got Hal here. What do you think Hal's concerns are? What do you think Hal cares about? Flying and stitching, yeah. right? He could care less if he has 90 to 145 degrees of motion. Doesn't care, right? You're like, you talk to him about, well, you're only at 90, we want to get you 145. He doesn't care about that. He has no idea what that means. What he cares about is, what are you going to do for me, right, to get me back to flying, right, to pay my bills? I often say that patients tune into one radio station. Does anyone know what radio station they tune into in their head? The radio station is WIIFM. That's the radio station every patient has in their head. Does anyone know what that stands for? Has anyone ever heard that phrase before? WIIFM is what's in it for me. That's what patients care about. They don't care if you meet your units. They don't. How does that affect them? It doesn't. If you don't meet your units, right? They don't care if they're late to your appointment and you're being late messes up your next appointment. They really don't. Right? They only tune into one station. This is sad to say, but it's true. They only tune into what's in it for me. Right? So we need to convince Hal here, whatever we're doing is in his best interest so that he can get back to his work and get back to his hobbies. Let's look what the evaluation found here. So we're going to just go down to Minimus Testing here. So tone is normal bilaterally. So that means the muscles themselves, there's no spasticity, there's no flaccidity. He's kind of an average ordinary guy. So he's got pain in the right anterior shoulder that is constant. And he describes the pain as aching and sore. If the pain is aching and sore, what does that tell you about the pain? What type of pain is it? Yeah, it's muscle or musculoskeletal, right? Aching and sore is usually a musculoskeletal problem. At worst, his pain is 10 out of 10, right? So at worst, he's, literally needs to get drugged to the hospital. And almost every single pain, almost every single patient's going to say, well, at worst, my big toe pain is 10 out of 10. When my little toe hurts really bad, it's 10 out of 10. Really? You need to go to the hospital? Just accept it. Don't judge them. But at best, he's a 6 out of 10. That's not very good, right? Currently, he's at an 8 out of 10 when he comes and sees you. So we know he's living in a state of pain, right? So what does that mean about the pain in his head? Is he constantly thinking about it? Yeah, right? And the more he thinks about it, guess what probably happens to the pain? It gets worse, right? So this is one of those where we might have to do a little bit of psychology with him and kind of get him out of thinking about the pain. So let's look at the range of motion. So one of the things I look at when I'm doing this, one of the first things I'll do is look at the non-affected side. So the non-affected side, his shoulder's within normal limits. So we know that he should be within normal limits, right? Because his left side's fine. So then we've got to worry about the affected side. His flexion is 0 to 105. How much is he missing? How many degrees? About 75 degrees, right? Extension 0 to 10. Is he missing some extension too? Yeah, he's missing some extension too, right? Abduction's 90. Ooh, definitely missing some there, right? Supposed to be 180, he's missing half of it. Internal external rotation, 20 to 30 degrees. That's pretty common for a patient that's got an arthroplasty. That's actually good. Most time I see them, they're like 10, 15. So he's probably done a little bit of work in the hospital. So we know he's going to have problems, right? So with these ranges of motion, what's he having a problem with in daily life? What do you think he's having trouble doing? Think of some activities of daily life that he's having problems with. Dressing. Yep. Yeah, putting on a shirt's probably the big one, right? Because he hasn't quite figured out how to do it. Washing the hair, right? He's probably already shaving his head. Even brushing your teeth, right? Because that takes a lot of internal rotation to maintain it. Right? What about, you know, driving? Yeah, driving's gone probably, or he's doing the good old lean back left hand driving, right? It always scares me when this patient's got this limited range of motion. He's coming in and he drove himself in, and I'm always like, oh. And then he's like, yeah, I'm on like 5 different pain meds. Oh my god. Right? And you're just like, oh, how are you? No. It's like, well, should I drive home? And you really want to say, no, park your car and leave it here. Call an Uber. Yeah, exactly. So we know he's got a lot of issues going on here with the range of motion. So that's going to be our major focus. Let's look at manual muscle testing here. Manual muscle testing. Again, they don't have anything on the left, so most times if there's nothing indicated on the left, it means left is usually 5 out of 5. But shoulder flexion, 2- out of 5. Is that a problem? Yeah. That means what? What does he have as far as strength in that shoulder for 2-? That's poor minus, right? Yeah, he only has partial range of motion, gravity eliminated. But wait a minute. It says that he's got 105 degrees. Well, again, remember, when we're measuring range of motion, you got to look, is it passive or active? In this case, we only measured it passive. Why do you think we only measured passive range of motion? Why do you think with the patient that just had a surgery, we only measured passive range of motion? Pain? Or more importantly, probably the doc's orders. Yeah, the protocols. This doc probably says, hey, you're only allowed to manual muscle test him. No active range of motion for 4 weeks. We'll see what the PT's ordered down here. But all of that, 2- out of 5. So he's only got partial range of motion against gravity. He's got some problems. His balance, oh, look at his balance. His balance is seated EOB, EOM. What does EOB and EOM mean? Edge of bed, what's edge of mat, right? So sitting at the edge of the mat, he's independent. Does that mean we need a gait belt on this patient? Not really. I would still put one on him, right? But this is not a patient I'm really worried about falling off the edge of the mat. So it says he's independent with seated static and seated dynamic balance testing. So what does that tell you? What would static seated mean? He's just doing what? Static seated mean he's just sitting there and nice and still, right? And then dynamic seated balance means he's doing what? Dynamic involves movement. Yeah, so maybe he's reaching for stuff. Or maybe we have him turning his head while he's sitting in the balance. So overall, his balance is pretty good, right? Transfers and bed mobility. Supine to sit's independent. Bed mobility and supine is independent. So getting in and out of bed looks good. Ambulation right now, sit to stand independent. And right now he's walking about 75 feet independently. And his gait cycle looks good, but he's not got a reciprocal arm swing. Well, that makes sense. He just had surgery, right? But why do you think he's only walking 75 feet? What's probably happening to him at that point? Yeah, he's getting tired, right? You wouldn't think of it, but you lose motion of one of your shoulders, it wears you out to walk distances, right? Both arms can't help him with that energy conservation. So we got to be thinking about that, right? Got to be going, okay, well, how much do you normally walk, Hal? Well, I normally walk, 4 miles a day. Oh. It is partially because your body's trying to heal it. And the other thing is that when you're swinging your arms, you're actually using your arms to push your weight forward, and that conserves energy. So you're losing a lot of momentum, right? Chair's falling apart. All right. So his goal is to resume work as possible. Right? And he wants to resume cross stitch as soon as possible, and he wants to resume patrol of 2814 in the lantern corner as fast as possible. So he basically wants to get back to work. You guys will find common themes to my patients. So let's look at some short-term goals. And I don't need the short-term goals here, but there will be long-term goals as well. So short-term goals. The PT says, right shoulder range of motion to increase as follows. Plus 15 degrees to flexion and abduction to allow for normal ADL activities. So the PT is only worried about flexion and abduction right now. Basically saying, you know what, we'll get back internal rotation, external rotation, you know, we'll worry about extension later. You know, 10 degrees gives us ability to get behind our back. He's overall function for most of that extension, but man, that abduction and flexion is where his problems are. And then overall for that short-term goal, within 3 weeks, we want to get him to about a 3 out of 5. Is that a fair goal? Is that a reasonable goal? Yeah, that's pretty reasonable, right? Now he's going to think 3 weeks. Are you kidding me? I'm going to be out of flying for 3 weeks. I'm not going to be able to. And you're like, yeah, you just had surgery, right? Because he's going to be comparing all of his function to pre-surgery. And this is where you've got to come in with your smart hat and say, look, Hal, I know you want to go back to doing all the stuff that you did back then, but you can't look about back then right now. What you've got to look at is, right now, are you better than you were yesterday? And was yesterday better than the day before that? And was the day before that better than when you came out of the surgery? Because they've really got to take those surgical steps day by day. Because you really get depressed, especially if you've got something like a stroke or TBI, if they're comparing themselves to where they were pre-function or pre-injury, you know, pre-morbid condition. Because, man, it's just depressing. Pre-stroke depression is a thing. You're exactly right. Or post-stroke. Well, when I say pre-stroke, meaning thinking about where you were before the stroke. Authorized CPT codes. Oh, God, what are these? Did you guys learn about CPT codes? What does CPT stand for? Does anyone know that works in healthcare? Current procedural terminology. It is for billing. You're exactly correct. Good. Right? So what this is telling us with these codes down here is, you know, what are we allowed to do with the patient? Right? The ever important one is this one right here. What's 97110? Does anyone know? 97110 is our common one. That's thorax. Right? So again, do you guys have to know this on your first clinical? No. Right? The good news is if you ever get to the point where you don't know what these are, Dr. Google has the answer. You can just look them up, right? The main thing that this is important, especially when you actually become a true PTA, let's say I wanted to do laser with a patient. Pew, pew. And I don't know what they'll do with the sharks, but let's say I want to do laser. I've got to come down here to my current CPT codes and see if laser is in them. If laser, which 97532, I forgot off the top of my head. But if laser is not down here, right? So say I want to do laser application, cold laser. And laser is not down here in my eval. Can I do laser? No. Right? 9703, okay. Yeah, we don't get reimbursed for it anyway. That's the funny part. So I can't do laser. Can't do it. So what would I have to do if I wanted to actually use the laser on this patient? How would I get approved for it? Yeah, talk to the PT. Say, hey, you know, John, hey, Dr. Reskin, I'm thinking that laser would be really good on that surgical site on the anterior portion of his shoulder, so maybe we can get him loosened up a little bit. I think it would be really good. What do you think? Well, what do you think of the side effects of the laser? I'm blubbering, and so kind of go back and forth. Then the PT says, hey, you know what? That's a really good idea. Let's add laser to his protocol. you can't just automatically go do laser with that patient. You have to make sure that the PT inputs that as an authorized CPT code on their billing before you do it. Or more importantly, honestly, before you document for it. Because if you document for 97039 and the whatever your medical billing system is that you use, or your electronic health records, and it's not an authorized code, it'll kick that code out. So maybe you did 40 minutes worth of laser with that patient, you'll get no reimbursement whatsoever, and you'll lose those units when I look at you as a director of rehab for your productivity. So this is just telling you what you can do with the patient. Like, this has probably got gates, it got transfers, it got manual therapy. So most of the stuff we're going to do is good. The next thing you're going to see a lot of times is this here. Does anyone know what this is called here? Yeah, the flow sheet, right? Can everyone see that, or is that too small? Is everyone okay? Okay. So the flow sheet is what we're going to do with the patient. As you can see, I made this in 2017, so this has been around for a while. Now, normally, in a normal situation, you don't see the range of motions and the Minimus Testings in the flow sheet. I put this in here just so we can use it as an example in case you're doing the Minimus Testings. A lot of times, we're going to be doing these at least every week, right? We're going to have to do this. If we're seeing the patient, we need to be taking these measurements every week. So this is what we've got to do in one session. So we've got to do range of motion of the shoulder, right? So flexion, internal, external rotation, Minimus testing the shoulder, flexion, Minimus testing the shoulder, extension. Then we've got to get some girth measurements. Girth means we're measuring what? What are we measuring? Width, right? We're mainly looking for what's at the shoulder. Looking to see if the shoulder is edemus, or what's the other term for edemus? Swollen, right? And if you look at this, he's 57 centimeters on the right, 54 centimeters on the left, 44, 42. He's not that bad, right? That's centimeters, so you're talking less than an inch difference. But in this case, and all of these people that I've created these were all my patients at some point. I always create them based upon patients I've seen. So why do we do these girth measurements? Well, this doctor that I saw for this, that did the total arthroscopy of that shoulder, requires the girth measurements to be taken every visit. That's part of his protocol. And by the third visit, the girth measurements are normal, but you have to continue those girth measurements the whole time you're seeing him, because that's what the doc orders. It's kind of silly, but that's what the doc's protocol is, so that's what we do. And then we're going to take some vitals. So normally we'll have some exercise, and we'll add some exercise to this in a little bit. So let's talk about going through this. So we've got to do goniometry of the shoulder. So let's think shoulder flexion goniometry. What position do we put the patient in for shoulder flexion? Do you remember? For goniometry, not manual muscle testing, goniometry. Supine, good, right? So we're going to be, I'm going to shrink this down here a little bit. We're going to put them in supine. All right? What's our fulcrum? So supines for flexion, let's do this. So just flexion. So in supine, what's our fulcrum for that? Okay. For shoulder flexion. In the glenohumeral joint, yep, that's okay. What bony landmark? Did I say there's two different ones you can use? Either the AC or the, and I told you your book used, not the groove, but what makes up the groove? What's the big thing that makes up the groove? The greater, the bump up here, the greater tubercle, right? So our fulcrums are either, depending upon, it could be the actual the acromion. But again, your book says greater tubercle. Okay. So then our stationary arm. What are we going to line our stationary arm up with? You remember? So we got the fulcrum out here. The stationary arm is going to come down the arm. Deltoid tuberosity would be good. Let's go a little bit further down. You had it right before. Keep going further down. The lateral epicondyle, right? That's going to be both of our final position and kind of our starting. So we're going to start it. But once we move that shoulder, that lateral epicondyle is gone. So we're going to need something on the body to line it up. And a lot of times what they'll say is to line it up with the midline of the thorax. And remember, don't measure off the midline of the thorax. He doesn't like to be measured. Right? So you'll start at lateral epi. But eventually when you move them through flexion, the lateral epi is gone. So you've got to have something to kind of line up with. So midline of the thorax is kind of where you're at. And then your movement arm, obviously, is that lateral epi, right? So let's say we're going to do this measurement, right? The first thing you're going to do is you're going to tell the patient, okay, we're going to take measurements of your shoulder flexion. This is what it kind of looks like. We're going to move it like this. So you're showing them. And then you're going to say, okay, and this is what it feels like. You're going to move them. That's telling them. And then you're going to get your bony landmarks. Okay, there's my greater tubercle. There's my lateral epicondyle. I can kind of see the midline of the thorax. All right, go ahead, Mr. Patient. Or is this Hal, right? Move your arm through that motion. And then you're going to get them. Is that as far as you can go? Okay, hold it. And you've got to be quick because he's in pain. He doesn't want to hold that, right? So you got to go, okay, there's my lateral epi. There's my greater tubercle. There's my midline of thorax. I got my measurement. And then you're going to come in here, right? And let's say we're documenting. So you're going to come in here and you're going to document what you found. So if the left says within normal limits, do you think we're going to have to check that every visit? Could you eyeball within normal limits? Yeah, right? So we always want to check bilaterally, right? So maybe the first time you work with them, yeah, measure bilaterally just to make sure that he's got both, he's got full range of motion on the left side. The second time, you just kind of line him up. Okay, let's see that left arm. He goes up to 180. You're golden. The only thing you're looking for is if he loses anything in that shoulder. Like maybe he comes in now, he's here at the left shoulder. Now we better get measuring because something's going on now in the left shoulder, right? So we'll document left is with the normal limits, right? So let's say that we got 110. So 0 degrees is our starting, 110 is our finishing, right? So he's able to change neutral, go to 110. We'll document that was our right. And then within normal limits left, right? Now I wish I could make this text smaller, but it won't let me. So we got that. That'll get squeezed into that first block. Boink, that's right there. All right, let's talk internal external rotation. What position for internal external rotation? What's our position for that? For manual, or not manual, range of motion. You could. It's going to be difficult. Remember, yeah, so remember with internal external rotation, you're always going to want to have them out at about 90 for measuring, right? Whether it's Minimus testing or whether it's range of motion. You could test here. There's nothing that says you couldn't. In the clinic, probably, yeah, you're going to test them and seated. I'm going to be honest, you're going to, right? But by the book, AJ's right. The position for internal external rotation is supine. Arm at 90 degrees of abduction. So out here, right? So what's my fulcrum going to be here? So I'm out here. What would be a good fulcrum on the tip of my arm out there? The olecranon. Okay, good. Now, the stationary arm is going to initially line up with what bony landmark at my distal hand? The styloid process. Good, right? And then eventually it's just going to stay put. That stationary arm's not going to move. So even though the arm moves, that stationary arm should stay as straight as possible. Ideally, it should be perpendicular to the floor. So at 90 degrees with the floor. Does that make sense? Our motion arm. What are we going to line up with again? Well, we lined up a stationary with it. We're going to line up our motion arm with the styloid process. And we're going to measure off. I can type today. So we're going to have the person go into internal rotation, measure it, have them go into external rotation, measure it. What are you watching for substitution with internal and external rotation? What are you making sure he doesn't do? How could I cheat and get more range of motion? Yeah, I can lean, right? Or you can see my shoulder pick up like this, right? Because what I'm doing is using my posterior aspect of my shoulder to pull me back into it a little bit more. So as long as I'm laying nice and flat and I'm like, okay, there, you got my range of motions, we're good. So let's say nothing's changed here. So IR is 0 to 30, ER 0 to 20, and rho B within normal limits left. All right, so we got our range of we've got our external rotation, internal rotation. Now we're going down. Let's look at the Minimus testing. So now we're going to test his shoulder flexion. Now all you guys that are excited about seated, what's my position for shoulder flexion Minimus testing? Seated, right? So we're going to set him down. He's going to go against gravity. That would be if we know that he's got a 3. But if you look, he's got a 2+. Now, here's the deal with manual muscle testing. You always start in the 3 position. Always. If you come in and his manual muscle testing is a 2-, last session, that's fine. You still start in a 3 position because you've got to see if he has any range of motion against gravity, right? Because 2+ says he's got some range of motion against gravity, full range of motion, gravity eliminated. What happens if you come here to him and he's like, okay, now he's got full range of motion against gravity, or full functional range of motion against gravity? Well, he might be a 3 now. So you've got to pay attention to that. And technically, looking at him, he could never be more than a 2+, actually technically a 2-, really, if you really want to be hardcore about it. But most of the time, we're going to measure him on functional strength, more so than does he have a full 180 degrees of shoulder flexion. We want to know if he's functionally strong enough to get through the whole range of motion. So let's say he's sitting here and you're like, okay, so again, what I want you to do is I want you to do this for me. You're going to bring your arm up for me as much as you can. Come and hold, grab him. So this is what you're going to feel like. All right, Mr. Jordan, I want you to go ahead and do that for me. And he gets about here and his arm drops down. Now what do we do? Because now he can't go against gravity fully. Now we need to move in to eliminate gravity, right? In what position do we go in for gravity eliminated? Sideline. So now we lay him down. Again, we're going to move him through the range of motion so he can feel what it feels like. Even though we just told him, this is what you do. You want to make sure you're very clear. This is what I want you to do, Mr. Jordan. Oh, okay. Yeah, that makes sense while I'm in sideline here. Now, for whatever reason, he gets most of his range of motion in sideline. What grade do we give him? 2+, right? So we'll say that he was 2+ here. So we had 2+ out of 5, right? Within normal limits left. And again, all this has to fit in these blocks. Individual blocks, not multiple blocks like I have here. All right, so we tested shoulder flexion. Now we're going to test extension. What position do we put him in for shoulder extension against gravity? Shoulder extension against gravity. Prone, right? Let's throw a caveat. Now this patient is bariatric and can't lay prone. Could we test him and seated? Yeah, you could do edge of bed, right? So that's the thing. So it would still, this technically still would be against gravity, but it's better to do it in prone. So we get him in prone. This is what I want you to do, Mr. Patient, is come back like this, right? And they lift up, and he's only got partial range. You put him in sideline. He's able to get as much range as possible out of that extension. He's a 2+. For both of these, for shoulder flexion and for shoulder extension, where are you going to apply your force? Where are you going to put your hand if you have to test him for a 4 and a 5? Are you going to go all the way out to the wrist? Now, this guy we can't test because he doesn't get that much strength. But where would we apply it if we wanted? Yeah. So maybe the forearm, but ideally just above the elbow. Right? We want to put most of the force on a short lever arm. Because we go all the way out here, even some of you like Dylan, if I tested, I'm pretty sure that I could probably break Dylan. Oh, not break Dylan. That sounds bad. I could get Dylan to break in the break test if I put full pressure out at his wrist in shoulder flexion. That's just a really long lever arm, right? But if I bring it back and I'm on just those condyles, and that's what I usually use. I use the condyles of the humerus as my goal. Kind of go in and get a hold of both condyles with the good old lumbrical grip and push down, right? That'll help me. Now, do you remember what's the difference between the test for shoulder flexion and that special test for upward rotation of the scapula? What's the difference in our force when we're testing there? For shoulder flexion, which way does our force go? Yeah, right? So push down, push up for shoulder flexion, and then with that one where we're testing that upward rotation, we add a rotational component to it, where we come down and in. All right, girth measurements. How many of you guys measured the shoulder before? How many of you would freak out right now in your clinics? Because you've never, right, I've never measured the shoulder. This would be a time that you would go, not sure how you do this. Can you show me what you do? Right? Now the PT or the PTA is probably going to do the good side because they want to show you what it looks like on a normal side. And then your goal is to go over here. But if you had to think about this, right? So are we going to have the patient take their shirt off? Yep. Or at least, if nothing else, get their arm out of their sleeve, right? This does not count. Right? I can't roll that shirt up enough to get where I need to be. And now I've created this roll of shirt in my armpit. And that's going to throw off your measurements. So that means you need to get them out of it. So what could you do? Well, you could have them bring their shoulder in like this and bring their shoulder out of their shirt. Right? Or you could give them a gown. Right? And have them slip the gown off. But remember, again, if you're dealing with a guy, probably not a big deal. You tell Hal here, like, Hal, hey, you know, I need to get measurements of that shoulder, and Hal's probably already taken his shirt off. He knows it's coming, right? But if you have a female, be aware of that, guys. Don't just look at a female and go, can you take your shirt off for me? Probably not going to end well. I'm just saying, right? So that's where you got to be, you know, probably a female. What I'm going to do is I'm going to give them a gown to change into while I step out. And I'm going to have towels where I'm draping when I'm taking the measurements. But let's just think logically for this. So what is our main point we're going off of for these girth measurements? What's our midpoint? Looking at these measurements on the sheet. Our midpoint is our acromion, right? So even if you're totally freaked out, try it. go, okay, well, let me see, have, you know, your CI standing over your shoulder going, seeing if you can do this, right? Get on, find the acromion, take your little skin marker and put a mark. All right, so I've got my acromion process. And it says you're going 1 inch superior and 1 inch inferior. So I got my acromion here. I'm going 1 inch down, and I'm going 1 inch up. What you're measuring for at that point is joint swelling in the actual joint. Right? You're not caring about muscles at that point. All you're looking at is, do I have a lot of swelling here that's limiting my shoulder range of motion? Could that be why he's only at 110 degrees if he's got swelling in that shoulder? What do you think? Could that be limiting him? Yeah. Right? Maybe the problem isn't muscular. Maybe, and even the pain. Maybe the pain isn't muscular. The pain may just be swelling, compressing everything. With looking at his measurements, probably not. Right? But it could be the problem. So you're going to come in, find that acromion. This is where you've got to get good at those bony landmarks. There's my acromion. I'm going to come up an inch, down an inch. And I'm going to make 2 lines so that I have something to go off of. When you're measuring a shoulder, and this is something that it depends upon your clinic, but most clinics, the line is going to run through the axilla, so through the armpit. And then it'll come up and around that 1 inch down spot. It'll come up and around the acromion, and it'll come up and around that 1 inch high spot. That's all there is to measure the shoulder. There's not a lot of voodoo behind it. There's even a figure 8 measurement of the shoulder, which we're not even going to get into. But I could see how, as a new clinician, that would freak you out. Like, oh my God, I didn't learn this in school, right? Because we can't teach you how to measure every joint. It's not going to happen. There are too many joints, right? Especially in Nevada, there are way too many joints. All right, somebody got it. So we're just going to measure off that. Now, the key thing here, when you're measuring girth, you need to match the units of your previous clinician. Because if you come in here and measure, 20 inches and 21 inches, and then, 19 inches and 18 inches, and they did them in centimeters, it messes the whole system up. Most clinics should have switched to metric by now because most of the electronic health records are requiring metric, but we still got those stalwarts that say this is America, and in America we measure in inches and feet. It is what it is. You measure with whatever the previous person does. The person did, inches or centimeters, you do centimeters. All right, let's look at the vitals now. So we got to go down and do his vitals. So blood pressure. What is missing from the blood pressure measurement? Yeah, millimeters of mercury. There's no units. Good. What else is missing? That should be on there at all times. MMHG, you need to put the units on. It's also missing what side you took it on. Right? You should indicate whether you took it on the right upper extremity or left upper extremity. Right? Because it's important to indicate that so that if I follow you as a PRN PTA, I can duplicate everything you do down to the last second, even if I've never seen this patient before. So you should indicate that, like, this should say in that blood pressure, I did it on purpose so that we can talk about it. It should say 145 over 95 millimeters of mercury, right or upper extremity. Right? Hypertensive. Is it okay to put that? Or is that diagnosing? What do you guys think? Okay, it is okay. Why? Because some PTs will say, oh, you're diagnosing here, right? And we're not. It's a hard fact. That's exactly right, Adrian. We're not saying why he's hypertensive. All we're saying flat out is his blood pressure when we took it is hypertensive, right? We go to that chart by the American Heart Association, 145 over 90, and I think that's actually hypertensive too, if I remember correctly. I think it's HTN too. right? And that's probably what I would document. I'm pretty sure it is. I don't have the chart handy, but looking at that, that looks bad, right? Why might his blood pressure be up though? Let's think a couple times here because his heart rate looks pretty normal. Meds could be due to pain. White coat syndrome, yeah, right? What's white coat syndrome? So anyone, I know Erica probably knows, but let's see what everyone else. Could be caffeine. Yeah, that's definitely me. Well, not right now, but yeah, right? You're taking measurements of him. He's freaking out, right? Because you determine if he can go back to flying, right? And that really bugs him. Like, you know, who are you? Probably at comps all day, exactly, right? You've got to think about this though for a fact, because, and this will happen the more you get people that have higher levels of degrees than you guys have with associates in physical therapy. Like you get somebody with a JD, a Juris Doctorate, and they're in there and you're determining if they can return to work. Man, some of those people can get real nasty with you. Who are you? You've got an associate and you're telling me I can't return to work? Yeah, buddy, I am. Right? Because I have the power. I am right now He-Man. Or She-Ra if you want. I can get the PT for you. Just stand your ground. You are the expert in this. They aren't. If they get really nasty and testy, yeah, maybe get the PT. But here's the deal. Is I've had that happen a few times, and I just tell them, look, I'm not going to come to your job and tell you how to do yours. Dermatologist, exactly. I'm not going to tell you if you got a foot fungus, right? But I'm going to tell you if you can go back to work safely. That's my expertise. All right, so let's look at heart rate then. What are we missing in heart rate? BPM, we're missing the units. Good. What else are we missing? Yeah, the side and where, right? So normally, where do we take heart rate at? On most average ordinary patient, where do we take it? Radial, right? But you need to make sure that you take heart rate on the same side again, because again, that can vary drastically by patients. So, you know, like my left heart rate's a little different than my right heart rate. So you want to make sure that you're consistent. And it's mainly due to the blood flow and everything else that goes on in my thoracic outlet, right? So if you take it on the left side, you want to make sure you take it on the left side. Let me give you one piece of advice as a new clinician here about taking vitals. Do not try to take radial pulse while you're doing blood pressure. I've literally had people freak out on me. Like the students are like taking that and they got the blood pressure cuff on, they're pumping it up. And like they give me this look and I'm like, did they lose their pulse? Yeah. And I just kind of get this evil grin. And the patient's like freaking out. What do you mean I lost my pulse? Right? So make sure you don't do something silly like that. That also includes if you've got a pulse ox unit. Don't put the pulse ox on the same side that you're doing blood pressure on. Because while you're doing blood pressure, what's the pulse ox going to start doing? It's going to start beeping at you. And patients don't like beeping. Right? Put it on their normal side. Take the blood pressure or the right. So most time, if you can take vitals on the left side, try to take vitals on the left side. Why do we want to try to take vitals on the left side? Yeah, specifically, what about the heart? It's the shortest, most direct route. Yeah, it's closer to it, and it's the shortest, most direct route, right? The arteries going to the left side don't bifurcate. They don't split, right? That's why that was the old theory of why people wear wedding rings on their left ring finger, supposedly, right? Because if you wear it on the left ring finger, it goes straight back to the heart. Isn't that cute? Aww. Right? And then the Europeans come and go, we wear it on our rights. We don't care about our spouses. But that evidently was an old school wives' tale as to why we wore rings on our left side. I often think probably the reason we wore it on the left side is because most of us are right hand dominant and we didn't want the ring getting in the way, but whatever. Or you're like me and you can be married for like 15 years and not have a wedding ring. All right, so normal indicates what? So this says normal and thready. Normal indicates the rate. So what is normal for pulse? 60 to 100, right? So as long as he's within that 60 to 100, he's normal. What if he's 105? What would you put down then? Tachycardic or tachy, right? And then if he's under 60, he's part of the Brady Bunch, right? What does the thready indicate? That he's thready for therapy? Yeah, thready indicates the feel, right? So thready is a unique feeling when you're doing pulse. And it's described exactly like it is. It feels like there's a thread being pulled through the vessel. So you get this weird kind of zip going underneath your finger, almost like you're, you know how you get that, the EKG kind of beeps and moves through the whole thing? That's kind of what it feels like as it's going through. You can almost feel it kind of pump through. You could have normal and regular. Normal and regular indicates what? Person's normal, right? Most of us would be normal or regular. For me, you would probably list mine as normal and irregular. Why do you think you list mine as normal and irregular? And Erica's seen my EKG, so she knows it's not normal. Right? Because my heartbeat is, I've got the Terminator heartbeat. Right? I'm just joking. I don't have the Terminator heartbeat. I've just got a weird, I've got usually a double beat than a single beat with my heartbeat. I've got an irregular beat to my heart. So that would be putting down irregular, right? You could also put down strong. What would strong indicate? Yeah, loud, not so, and loud. Remember, when we're doing pulse, we're doing it by touch, right? Unless you're oscillating at the heart. But at the finger, a strong beat is a boom, boom. You're really feeling it. Usually, if they've got a strong beat, they've got high blood pressure, right? Because that blood pressure is just being forced out. It's a very prominent blood, yeah, right? Very unique. What about absent or minimal? What would that indicate about the pulse? What would it feel like? It's very rare that you're going to put absent, but minimal is common. Yeah, it's really weak and barely feel it, right? Those are the people that you're like, I got it. Don't move, right? Because if they move 1 centimeter, you lose their pulse, right? You may have to change to a different spot, exactly. When you're taking pulse of any patient, if you're having problem finding it distally, you should move to the next most proximal spot. So if you're having problem at the wrist, you move to the brachial pulse. If you're having problems with the brachial pulse, where should you move to next? Carotid. If you can't find carotid, what's your all-time best place to take pulse? Yeah, the apical, right? Well, temporal doesn't always show. You're going to go apical. And in order to take apical pulse, you need to have a what? Good. Where do you measure apical pulse at? Bottom of the heart, good. Under the 5th rib. How do you find, let's go this way. How do you find it using body landmarks? Because finding the 5th rib can be difficult. What do you use as your landmark? Yes, under the nipple. If you find the clavicle, run down to the nipple. That's where you're going. It's going to be in this region right here, right? If you have a female, guess what you have to go under? under the bra and under the breast, right? Because you need to get in where you can feel it. Or sometimes the guy, too, you might have to go under the breast if they've got, moves, right? So guys, what if you have to take apical pulse of a female and you have to get under their breast? How could you do that and not get a sexual harassment suit thrown at you? Do you want to just reach under their shirt? Yeah, get consent first of all. Can you lift your breast and then you drape, right? I'll oftentimes tell them, can you roll up your shirt and lift your breast with your shirt? Now I can get under it, right? Yeah, that doesn't work out so well for me, just letting you know, right? What if the patient's comatose? Should you still tell them what you're doing? Yeah, still tell them. Talk to that. You'll be amazed. When you guys see a comatose patient, talk to them. Hi, Mrs. Johnson. I'm going to go ahead and take your pulse on your heart here. All right, so I'm going to lift this up out of the way. We're going to go right on that. Talk to them, because there's a lot of studies that show talking to a comatose patient gets through to them. And there's cortical mapping that shows that when people talk to them, there's results in the brain. Even if they may not be able to hear you, the brain is responding to it. So do talk to them, right? But guys, just be aware, and you're going to have to. I've had little old ladies who are like, okay, I need to take your pulse. And they know that it's coming under their chest, and they're just like, here you go, Sonny. Put that thing away. Right? So be aware of that. Just have them clear it for you. If the patient can't clear it, what if there's a stroke on that side? Well, then you will have to help them, but please make sure, get a towel, right? Get a towel, roll it up in your hand. All right, I'm going to go ahead and lift your left breast up to get your pulse, right? Don't just be like, I'm going to lift your breast up. Even though we work in the medical field, you want to limit your exposure to lawsuits is what I'm saying. All right, so we don't have a lot of exercises here because this is kind of a patient I didn't put a lot of exercises on because we don't have a lot of exercises for this semester. But let's think of some, and we'll take a break here briefly, and we'll look at the second example here. What kind of exercises could we do with this patient? We haven't talked a lot about shoulder exercises. Well, we're going to stretch them first of all, right? Probably got a little bit of stretch going on in that shoulder and do some passive range of motion. Here's the interesting thing. The position you put the patients in for manual or for goniometry is your best position to stretch them in. Y's and T's would be great, right? Y's and T's. Good. He's a little too early for that at this point, but wall walks are great. Isometrics, right? In against the wall, in against the body, down, up. Wall walks are great. We're going to have him put his fingers in the wall and climb up the wall and climb down the wall. And then make circles. Pulleys. Excellent idea, right? See, you guys don't even have a ton of experience, but you're already thinking of some of these. Right? So don't total freak out. I know this first clinical is going to be scary for you. And we may not have covered exercise for, something. What about shoulder flexion? Let's say we wanted to strengthen shoulder flexion. If you can't think of an exercise, here's a little hint. So for stretching, to stretch them, put them in the position that you did goniometry in. So if I want to stretch shoulder flexion, I put them in supine. I bring them up and I stretch them into flexion. Internal, external rotation, right? I put them out here at 90. I can stretch them into internal rotation. I can stretch them into external rotation, right? For strengthening, find your manual muscle test and turn it into an exercise. If you can't think of anything else, turn that into an exercise. Could I give him a dumbbell and have him go up and down with a dumbbell? Would that be an exercise I could have him do? Sure, right? And that's the manual muscle test, isn't it? Shoulder extension, my manual muscle test is prone going back. Sleeper stretch would be one we could do, right? We're kind of stretching out that shoulder. All of these would be valid. The main thing you have to pay attention to is this patient probably has no active range of motion allowed. If it is active, it's probably active assist. So with active assist, the pulleys would be a good idea. The isometrics would be a great idea. right? Walking in the wall is considered active assist because you're using the wall, right? I prefer, honestly, the finger ladder to the wall if they have one. And finger ladder is nothing more than a vertical ladder that they can walk their fingers up, right? Thanks, Clarice. Be safe. Towels. Towel on the wall, right? And you can turn that into a stretch. So they can be using the towel to slide up, and that's doing active assist. They can use their other arm. They get up there, and then they can lean into it and stretch a little bit. Right? So all of those are fair exercises. Wax on, wax off, right? Exactly. Canes, right? Give them a cane where they're lifting up with one arm and lifting the other arm up. All of those are valid. Does that make sense? We doing okay? Do we want to look at another one, or do we want to take a break quick? Do you want to power through and get out here early? What's everyone think? All right, power on. Power on, Garth. Power on, Wayne. Oh, wait, no, it's party on. All right, let's look at number 2 here. And this is just, there's a soap note. I've posted these. They'll be active for you guys to look at today, just in case you want to look through them. All right, so we got Gonzo Larfleeze. He is a 62-year-old male who is 4 weeks status post fall on left outstretched hand. What is that called again? Whoosh, right? Subsequent scaphoid fracture and is being seen in the outpatient clinic. Good thing he's 62, because if he was 65, he would have broke his hip. Just kidding. All right, so his active concerns. I'd be really concerned if I have RITS, range of motion problems too. I'm hoping that was a misspelling on my part. That should be wrist range of motion. He's lost his wrist range of motion. He's got generalized left wrist weakness, lack of normal mobility, inability to perform functional ADLs, pain with writing. Patient is left-hand dominant. I'm going to speak from experience. This is literally a pain in the hand. If you are left-hand dominant and you lose the ability to use that left hand, or if you're right-hand dominant, you lose the ability to use your right hand. It's really hard to use the other hand. Decreased ability to perform self-care ADLs. Oh boy. Let's look at his past medical history. Oh boy. So what strikes out here with this patient? So from our standpoint, in the physical therapy standpoint, we're looking at the diabetes mellitus 1. Right? So he's on DM1. What's kleptomania? Does anyone know? Yeah, he steals things. Right? So he's got diagnosed kleptomania and oppositional defiant disorder, ODD. Right? Now, I'm of the proponent of the position that you cannot diagnose ODD. Yeah, he needs his left-handed or steal stuff, right? I am a position that you cannot diagnose ODD until somebody is 18 and they're mature. Or not mature, but at least past puberty. A lot of kids get diagnosed with ODD really early. And really what it is the kid being a freaking kid. Right? Kids aren't necessarily oppositional, they're just kids. Right? You tell them to go clean a room, like, they're not being oppositional, they're being a kid. Right? 62, this guy probably does have ODD. Right? So he steals something from you. What do you think he's going to say when you say, hey, you stole that from me? No, I didn't. Right? This guy is literally, if you've ever played Dungeons & Dragons, this guy is a Kender. He steals stuff and says, no, you gave it to me. Oh, Jerry knows what I'm talking about. Haha. You must have dropped this. If you guys don't know what it is, I highly recommend reading the Dragonlance series of books. All right. Patient is an ex-astronaut who is retired and resides in a single-story home within city limits. No stairs to enter the home or stairs inside of it, so that makes us good. Patient enjoys gardening, especially for citrus fruits such as oranges. Right? So you're thinking that a guy that's a kleptomaniac couldn't be an astronaut? Is that what you're saying, Erica? Are you judging him? I'm just joking. So he's an ex-astronaut who's retired and resides in. You'll be amazed at how many people you run here that are astronauts. The oppositional thing makes me believe it. Maybe he's on meds. Right? And that's the only thing I don't have here is I don't have their meds. So let's look at his tone. Normal bilaterally, left medial hand wrist pain just distal to the radial carpal point, constant and throbbing. Throbbing is an indication of either blood issues or probably a fracture. So we know he's got a scaphoid, right? He's got a scaphoid fracture. Look at this, though. His worst is a 10 out of 10. His best is a 3 out of 10. So we know that he can get pretty decent on his pain. The other guy is 6 out of 10. We know he can't, right? He's currently at a 6 out of 10, even though he probably tells you that it's not, right? He's going to argue with you everything. Looking at his left wrist, this patient's a passive range of motion person. He's got 15 degrees of flexion, almost none. Really almost no extension, right? Is he missing a lot of all of his range of motion? Look at that, radial deviation, ulnar deviation, right? Man, he's almost got nothing. And what do you think the end fields are of all those? Empty. Yeah, I should have put that on here. I should actually add that when I edit this because they need end fields, right? So he's got an empty end field. He's fighting everything you do, right? Wrist one, within normal minutes. Watch your goniometry though; it may vanish. So pay attention when you lay stuff down. I got the best patients here, man. Strength, left wrist. So again, we're at 2- out of 5, which means he can't do against what? Gravity, right? And he definitely only has partial range of motion. So overall, again, this patient is pretty good. Look, independent. His gait is 75 with overall normal gait cycle, literally lacking reciprocal arm swing because he's guarding his arm. What's he walking around look like? Where's his arm probably at when he's walking? Yeah, side or probably like this, right? He's walking around with the arm resting on his chest, and he's the type of patient the doctor probably put him in a sling coming out of the hospital, and he's still in his sling, right? And this patient was still in his sling. Not all of this is the same as the patient. I added some fun things to it as well. Yeah, so he put stuff in it, right? Exactly. Patient's goals, he wants to resume gardening as soon as possible. He wants to return to the casinos. That sounds safe. And resume normal activities daily. So he just wants to get back to normal life, right? He's probably retired. As an astronaut, he's living on a government pension. If he wants to go down to the casinos and gamble, you know what? More power to him, right? So short-term goals is to increase his range of motion by about 10 degrees in flexion extension and 5 degrees for radial ulnar deviation. 3 weeks, that's pretty reasonable. We probably could get a lot more than that, but this PT is just being kind of cautious and going, yeah, 10 degrees is a good goal. We want to get him to a 4 out of 5. That's not a bad goal. I think that's a little aggressive, but I mean, it's not undoable, right? That means his patient's got to put some work in, right? And there's our authorized CPT codes. Let's go down to the flow sheet here. All right. So we're going to do some goniometry first. So let's talk through the goniometry. Wrist flexion and extension goniometry. How are we going to set the patient up to measure this? Seated, good, right? On a desk, good. What are we going to put under their wrist? Yeah, we're going to get a towel roll, right? Put a towel roll so that we get a little bit of elevation of the wrist, right? So now once we get that, we're going to kind of measure them. So let me get this camera pointing down here, right? We're going to put them off the edge of the desk. But remember, for range of motion, they don't have to go against gravity. We're just measuring how much they have, right? So we're going to get them off. We're going to measure flexion, letting the arm drop. And then we're going to roll over. And guess what we're going to do with the extension? Let the arm drop. The good news is your manual muscle test, guess what position you're in for manual muscle test of the wrists? Seated. Yeah, you're in the same position. The only difference is, for a range of motion of the wrist going into extension, you're here, you're dropping down, you're coming up for manual muscle testing, right? The wrist by far, when you get those range of motions, those manual muscle tests, those are probably my favorite because you don't have to do much with them. They're right there. I mean, you don't have to lift anything. It makes you happy. Makes me happy, at least. I'm like, God, I don't have to lift a patient out of bed. Thank God. Right? So let's think wrist flexion and wrist extension. What is our fulcrum for those? What's going to be our rotational point at the wrist? Rotational point at the wrist is going to be the styloid process. Very good, right? So rotational point's a styloid process. We're going to line up the stationary arm with what? Midline of the... Yeah, midline of the ulnar, midline of the forearm, right? Good. And then we're going to follow at what digit out for a range of motion? Right, the 5th metatarsal. I made you say it. Haha, that was great. Metacarpal. I got you guys to say it. That was fantastic. I love doing that. That's fan. I put that in your head too, man. You're like, as soon as you're like, tarsal sounds good. Right? So there, you got your lineups. You have the measurement, you're done. Right? You got your measurements. Now, wrist flexion, again, you first of all want to test them against gravity. So you're going to have him go off the desk and lift against gravity. If he can't do it against gravity, what do you do with the hand in order to eliminate gravity? For Minimus Testing. Yeah, you rotate it, turn on the side. Or you can drop it too. You could actually do it that way as well. Yep. Or you just turn to the side. So you're like this. And now he's doing range of motion like this. Either way works. You could actually do it with gravity if you really want to give him a little bit of bonus, right? So we've got our range of motions. Oh, look at this one. This one's a little bit better. We found an apical pulse. We've got our beats per minute. Whoever did this note was much better than the last person. It's almost like I planned it. Right? All right, respirate. This has a little bit different vitals. Respirate. How do we measure respirations? How are you guys taught to measure respirations? Okay, and I'm back. So depending upon your clinician, make sure, yeah, times 2? Times 4, that's better, okay. Make sure however you do this, the main thing is your patient doesn't know you're measuring their respiration. Don't tell them, I'm gonna watch you breathe. Because you tell me I'm gonna, and I'm like, right? Because then I'm gonna start focusing on what you're doing. My trick for doing it is I tell them I'm gonna listen to their heart rate. Or I'm gonna listen to their lungs. And I'm not actually listening at all. I'm feeling as it rises and falls, right? You can put your hand on their chest or hand on their back. Some clinicians, and I can't remember if Dr. Reskin requires you to touch them or not. I think she requires you to be able to measure without touch for next semester. But you really got to get good at doing some of these, you know, without touching your patient, because especially nowadays, we want to touch our patients as little as possible with COVID. So you can still see the chest rise and fall without touching them. We went through the heart rate already, but let's talk the rest rate. So it says he's 14 rests per minute. Normal means that there's no abnormality to the way he's breathing. What does 1 to 1 indicate? Because this is important to put on your, when you're measuring rest rate. What does 1 to 1 indicate? Close. Yes, right. It's per second, right? So that means if I breathe in for 1 second, I breathe out for 1 second, right? And it could be that I breathe in for 2 seconds and I breathe out for 2 seconds. That's still a 1 to 1 ratio. What that means is my time that I'm breathing in versus the time that I'm breathing out is equal, right? What if you had a patient that was COPD? What would it probably be? So it's always in to out. A lot of patients with COPD will be a 2 to 1, right? Where they're breathing in for 2 seconds and only out for a second. They're leaving residual volume. And eventually, what will happen is that residual volume will build up and they're like, and they've got to clear that lung. because they've got too much residual air sitting in their lungs, right? And that's where we're going to teach them how to get that air out. And for the COPD patients, we're going to flip it. We're going to try to get them to breathe for a 1-to-2 ratio so they get more of that air out, because it's harder for them to get the air out. All right, SpO2, how are we going to measure that? And look at their finger, right? Yeah, it's kind of hard. You can't just look at their finger and go, you're about 90%, Rocky. You can't do that. You've got to put a pulse ox on them, right? If you put the pulse ox on them, can you use that as your pulse? Because pulse ox is going to give you a pulse, so I'm not going to measure his apical pulse. No, if it says do apical pulse, you do apical pulse. But you can use it as a comparison, right? Does anyone know what it's called if your pulse at your extremities is different than your pulse at your apical? What that condition's called? Actually, this one's not called peripheral anything, amazingly enough. It's called a pulse deficit. Usually the pulse at the heart is greater than the pulse out at the extremities. What is that probably telling you about their blood vessels? So if here you've got 60 and out here you've only got 45. Well, it could be they're too big. More than likely they're starting to get stenotic. They're getting hard and fibrotic. They've got arteriosclerosis, right? So the arteries, it's not pumping as well out to the extremities as it should. Now, there are other reasons for it too. It could be that you've got too small blood vessels. There's all kinds of reasons for it as well. Maybe you have a block. Oh God, not rhythmic initiation. No, Mr. McKeever, I hate you. All right, so looking at this one, it says that we're doing D1, D2, flexion and extension. So that means you're gonna go, does it matter where you start at if you're doing both? Nope, right? So you're doing 2 sets of 10 reps each. So D1, right? What's D1's, how do you remember that one again? Eat the apple and throw it away, right? So we're gonna have them come out here, up and out, up and out, right? Now it says rhythmic initiation. Do you remember what rhythmic initiation is synonymous with? Rhythmic initiation is the fancy PNF that is passive. So that means who's doing the work? Yeah, we are, right? And so what do you think, why do you think we're doing PNF on the hand? Well, we're probably just trying to get the hand to relax, right? We're probably just doing this mainly for relaxation technique, because it is very relaxing to have somebody do this to you, right? You may not look it, but when we do it in the clinic, you'll feel it. It feels really good on the shoulder and all the way out to the hand, except when you get out here and you get that kind of that nerve tingle going on like I've got. Couple key things with the flow sheets that I wanted to cover. When you have a flow sheet, you need to make sure you date every flow sheet. You also need to make sure every flow sheet has your initials on them. Yeah, time's usually going to be like time's usually going to be associated with your note. You may not need to put that always on your flow sheet. All right, so let's talk. So we talked about how to document. We've already did that last one, how to document. What happens if for whatever reason, we're going to stop doing PNF rhythmic initiation? How do we indicate that we're stopping that on the flow sheet? Maybe the PT says, yeah, okay. So we're going to come to this spot right here, and we're going to type DC. So we're going to put that in the box. And then what else do we have to do? Does anyone know? So you have to take a line. Yeah, we do, right? We know the date because we're already on the date box. We have to draw a line through the rest of the boxes. And then out here at the end of the line, we have to do something. Does anyone have an idea what we have to do at the end of the line? initial. That says I'm the one that discontinued it. If you put DC here, you cannot come over here and put another exercise. This line is for whatever this exercise is. That would be a problem with JACO if you do that, which is the company that regulates hospitals. Now, does that mean some clinics don't do that? No, some clinics do that. I'm going to tell you they do. This is the proper way to document for flow sheets. What if I wanted to add something? So let's say up here, I want to add wrist. Let's type because that looks really bad. Let's say I want to add wrist extension with T-band. Well, I'm going to find an empty block, and that's where I'm going to put it. Okay, so we're going to pretend like that's in that block because I can't make the date smaller. But let's say that we've seen the patient this day, so this block's filled, this block's filled, this block's filled, and we're all the way out here in this block. And this is the first day we're going to do it. Well, then we're going to put what we're doing it. So maybe we'll do 1 times 10. I can't write with this mouse. And we're going to do it with red TheraBand. What do we got to do to all these boxes here? Line. Yeah, we got to put another line here. And again, initial. Because we don't want anyone coming. So whenever you do documentation, whether it's this, whether it's written, whether it's in the system, whatever it is, you don't want to have a person be able to go back and edit what you put in place. I'm not saying that people ever would, but there are weird people out there that'll try to throw you under the bus, and if they can edit whatever you write in those sheets, they will. They'll make you look bad. So make sure that no one can come here and add something before this and say, well, why did you do it back here when you only documented that you started it here? Right? Does that make sense overall, though? People are sketched, yes. What if you saw this on a block? And you go over here and it says that. What does that mean? It says HEP in 3 minutes. Does anyone have an idea? Home exercise program, good. What's the time indicate? Maybe not the length of it, the time spent doing what? Because we're not going to have them do their HEP. Yeah, right? Explaining or reviewing. Right? So what this would say is HEP 3 minutes. It means that you sat down and, say Dylan was my patient. I'm like, all right, Dylan, so how's your home exercise program going? And he's like, oh, okay, well, tell me which exercises you're doing, which ones you're not doing. Dylan's like, oh, I remember doing this one and I'm doing this one, but I really don't like the one where I'm going out and drawing the sword. Right? It's explaining, going over the home exercise program to make sure that the patient is actually what? Doing it. Yeah, right? Because you sit down with Dylan, Dylan's my patient, and I said, so tell me about your home exercise program. And he's like, well, I'm doing it. Oh, really? Can you show me some of the exercises? Oh, I really can't show you without my sheet. What's that tell you? He ain't doing them. Right? So you want to spend a little bit of time with your patient. He's lying, right? He's lying like a lion. You want to spend a little bit of time reviewing it. Now, some insurances will pay you for what that's called as patient education. But I usually put that on just to indicate so that when I put in my notes, reviewed HEP with patients, I can go back to my flow sheet and show that I actually reviewed it. Right? Again, your whole job as a PTA is going to come down to, and I hate to say this in today's day and age, It's going to come down to the CYB and CYA. If you didn't document it, you didn't do it. So you've got to be very specific about it. Let's get down here and just look at this SOAP note real quick, just so you can kind of see how this one's documented. So a patient is agreeable to TX. What's that mean? He said he gave what? Consent, right? I've seen some people putting verbal informed consent or VIC. It just depends upon if your place accepts that as an abbreviation, so don't automatically assume that. Patient reports 6 out of 10 throbbing pain at left radiocarpal joint. Let me ask you, if you saw that written, could you find exactly where that's at? Like if you were following me as a patient or as a clinician, could you know exactly where that pain is at this point? By going left radiocarpal joint. Yeah, that's how specific you want to get with your pain, if you can. Right? You want to be specific so that if I follow you, I can go, oh, so you're having pain right here, huh? And he's like, yep. I could even get more specific then. I could say that I have left pain at the left scaphoid. That would be even more specific, right? On NRS pre-TX or pre-treatment, and then 4 out of 10 post-treatment. Patient reports, I don't want to take my meds. Why did I put that in there? Well, it's something the patient said, and is that medically relevant? Yeah. What if the non-compliant, right? What if the patient's like, I got laid last night? Are you going to put a note? Patient reports, I got laid last night. Is that medically relevant? Maybe, I don't know if it's not really medically relevant for this patient, right? So, our patient says, I bought a new car. Not medically relevant. Right? But patient says, I don't want to take my meds. That is medically relevant. We should document that, right? It's agreeable treatment. So, in this case, this clinic allows you to say, see flow sheet for details. Great. What if you change something on the flow sheet? If you change something in the flow sheet, you have to indicate it in your O. Even if you put it on the flow sheet, you have to say, added X exercise and all the specifics of it, or DC to home exercise program, all the specifics and the exercise. Does that make sense? And the A again is just what I like to think of as your subjective. It's you telling what happened in the session. So patient tolerated session without incident. I put that in a lot of my notes. What that means is patient was able to do the exercises. And a lot of times you'll see this one down here. I put this in almost all of my notes. Patient goals ongoing and would benefit from continued skill therapy to progress towards assessed goals. That is what I call a CYA statement. Because what that's telling the insurance carrier or whoever I'm documenting, I'm going to be honest, I have about 3 statements like that I use on almost all my notes. That is a Mr. McKeever statement. You're free to steal that statement if you want. What that says is the patient hasn't met their goals and they need to keep seeing PT. So what is that doing to the insurance company? What's that doing to our services? It's reassuring them. It's justifying our services, right? It's continued reimbursement. Exactly, right? Even though I didn't really say, did I say anything specific in that at all? Not really. Right? All I said is they haven't met their goals yet. But at least they can look at it and go, oh, well, they are working towards their goals, hopefully, right? No changes in general range of motion today. So nothing's different, but noted decrease in pain after PNF. Notice I don't say the pain decreased by 2 points. The A should have really no objective numbers whatsoever. The A should just say things went up, things went down, things got better, things got worse. That's all you really need to document in there. Patient met a goal. Patient achieved goal 1. That would be a time mode to be okay to put an A in there or put a number in the A. But for the most part, this is just, did things get better? Did things get worse? What did you see? Did the patient have pain increase? Did the patient have a pain decrease? What did you see as a clinician, right? Was the patient substituting when he was doing wrist flexion exercises? That you could put down here. And again, this is another Mr. McKeever kind of staple. Continue treatment 4 times a week times 4 weeks per plan of care. All I'm putting is whatever their treatment time is per week. And then this is something lately we have to keep track of. Patient has 6 visits until reassessment by the PT. Why do you think I put that on there on all my patients? Who should be keeping track of if they need re-eval at a clinic? But who should be keeping track of that kind of stuff? Not necessarily PT, the administrative staff. Yeah, but the problem is I keep track of it now, and it's becoming more of a PTA responsibility because the administrative staff is handling 50 other patients. And it's not uncommon for a patient to come in and you look at their chart and you're like, oh crap, they need a re-eval. Right? It's a lot easier if I keep that. Yeah. If I keep this here and I'm down to, my last one was 1, and they see me and now I've got 0, what I can say to the patient is say, hey, on your way out, I need you to schedule with Sandy up at the front desk so that Dr. Reskin can see you next time. And then I can go up to Sandy and say, Sandy, they need a re-eval next visit. They can't see me. Oh, okay, good thing you caught that. Yeah, it is a good thing I caught that. Right? That just helps keep things situated. Nothing follows you can put when you do typed notes. You cannot put that on a written note. I mean, you theoretically could, but if you do it, what do you have to do to all this white space down here? So if you're writing a written note, anytime you have white space, so I have white space right here, right? After this, it's all white space. I have to line it out. Because again, I don't want anyone following me. And then I have all this white space down here. You don't have to do it as much as I'm doing it, but you just want to make sure that nobody can follow you and put something down there, right? I'm a big proponent when I do it. What I'll usually do is I'll come down here and do this. Now, if anyone writes anything in there, I know somebody else wrote it, right? But if you're handwriting notes, which a lot of clinics don't do anymore, a lot of them have, right? It's, again, all about covering your butt. Now, when you document down here, you have to document a couple things. You will have to sign their note. After your signature, when you become a PTA, you will have to put what your title is and what your license number is. What are you going to put there as a student? SPTA, right? That also needs to go by your printed portion of your name. Now, the good news is if you're doing electronic health documentation, those are going to automatically get applied to the record. They're going to have you sign something when you first go in, and that's going to be your auto signature. And it'll automatically apply every time you do a note. So you don't have to worry about it. But if you're writing handwritten notes, you have to sign your name and then write it out. Don't just sign it, because Medicare gets mad about that because we all have horrible handwriting. Like literally, I'm not joking, my signature, that's my signature. There's no one that's going to duplicate that, but at the same time, no one has a clue who that is. So you've got to print your name below if you're writing out your thing. The other thing you need to have is your supervising PT, their title, and their license. Now, Dr. Reskin, let's use her for an example. She's got about 50 letters after her name. She's got PT, DPT, LATC, CKTS. You don't have to put all those, right? You ideally want at least the DPT behind them. Does anyone know what CWS means? Anyone ever seen that on a PT title before? It's a certified wound specialist. And when they get stuff like that, they get kind of testy and want you to put, this was one of our previous instructors. What if you don't know your PT's license number? Ask, right? What if they don't know it? Their license is in the building. Go look at it. It's got the number on it, right? If you see an A dash, that indicates an assistant. What if I am your supervisor? I'm your CI. Can you write me down as your supervising PTA? This is where you're going to end at. Could you come down here and go, K. McKeever? No. Because my initials are this. NOTDPT. You could list me up in your note as your certified, your CI, if you wanted to. And a lot of clinicians do have you put that, like, co-signed by K. McKeever PTA, 80569. I cannot be your supervising PT. Even if you have a PTA as your CI, your PTA has a supervising PT. You need to know who that is. So that when you get first time to your clinic, that's going to be one of the jobs Dr. Reskin is going to have you do. You have an orientation to the clinic that you have to complete for her. Where's the fire extinguisher at? Where's the MSDS sheets at? Where do you go if there's a fire? Who is your front desk contact person? Who is your supervising PT? All of that you have to know as a PTA. They can be PTs or PTAs, right? Exactly. Now, I can't take a PT as a student. Does that make sense? Because, again, my initials are NOTDPT. I'm not a DPT. I can't do that. But I can take a PTA as a student. Does that mean a PT can't shadow me? Absolutely not. PT shadow me all the time. I think out of morbid curiosity. But I can't have a student that's a PT. I can't have an SPT. Yeah. More like, what is McKeever doing again? Does that help a little bit? And we've got some other ones we're going to go through when we get into lab as well. Does that help a little bit looking at it? Right? Because I know that I think Adrian wanted to kind of look through this as well. Let me stop sharing here. There we are. And bring this over here, and we'll stop recording.